here now in the ICU, and can you span the camera with a bit of modification for starting a normal? So at any time, any of the experts please pitch in. The audio is only with me, so we'll pass the audio to you. So Srikanth, over to you. So explain. You want to start with the DCD4 situation or something, your choice?
DCD4, we can just start with that.
Okay, so
DCD4 is a brain dead patient whose one set has been done, and before the second set has been done, the patient has become unstable. Right? The second set is not possible because apnea is not possible in those cases, and this starts to deteriorate and rapidly start to go down. So that's where DCD4 will come. Now, in an Indian setup, most of the withdrawal or even for DCD4 as DCD3 and 4 will be done predominantly in the ICU. That's what I presume, because given the unique dynamics, it's not as if the attendants are very willing, very eager to donate organs. So there is a continuous kind of interaction between the grief counselor and the attendants, and finally they come to an agreement for at least the interest to donate organs. So what I presume is that most of the things the interactions have to be done in the ICU itself. There's another option which is in the OT, we'll take that later, but I'll just talk about how do we go about in the ICU. So
I'll take the mic from you, you need both your hands, so you can...
In the ICU, we can just show the first of this. In the ICU, we're going to be using a hybrid ECMO CPP which has been assembled. See, the ECMO machine and its circuit is extremely expensive. Right? And availability is also an issue nowadays. So we have created what's like a hybrid low-cost ECMO CPP machine. So I'll just take you through the entire part of it. So it's got, as you can also see,
use both hands.
It's got a blue or a venous line that sort of draws the blood, and this is the red, this is the arterial line which pushes the blood back. Now if we just follow the venous line, how do we drain out the blood? First and foremost, we use two cannulas.
So let's start with the cannula.
Let's start with the cannulas. So this is our patient.
So let's start with what cannula we are going to use.
So we have the femoral vein, the femoral artery, and the contralateral femoral artery. These are the three vessels that need to be addressed. When the patient's BP starts to go down below a critical level, and the patient is either for withdrawal of life support or is DCD4, what we would be doing is, before the patient cardiac activity comes to a standstill, we are going to be cannulating the femoral vein on one side, the femoral artery on the same side, and the femoral artery on the opposite side. So we'll be putting a small sheath in all the three vessels. As the BP is going down, we are going to be heparinizing the patient. We'll be giving 30,000 units of heparin. Pre-mortem. Right? Once the heart comes to a standstill, then 5 minutes of no touch time, and once all this thing is done, immediately over the sheath we are going to be. So these are the three sheets we are going to be putting in.
We will do it again. The demo is for blind, we can't show everything. We can open it, we can always spend some time. Right.
So we cannulate in the real-time ultrasound guidance so that we know which vessel we are.
Any comments from any expert, please chip in.
So we have got one in the femoral vein, one in the femoral artery on this side, and one in the femoral artery on the contralateral side. Okay? So these three things are there. So once the patient has
So the consent of the family has already been taken for DCD, and the consent includes that we will have these in place. It's a part of what is the signature.
16 gauge.
So you have already taken a consent for DBD again, but after that it starts collapsing.
Yeah,
so you take a consent for DCD again or
again, because our consent for that is slightly different. So we'll have to explain. So this is basically for a very motivated family who want to donate. And Kumar, yeah.
Have a DBD consent that is on the proviso of a positive first and second acne test. You only have the first one. At what stage are you going to get the DCD consent done?
So as soon as the blood pressure sustained remains below systolic of 80, and I know that this probably this patient started to go down rapidly, that's the time we'll start to engage the patient's attendant. That in case the heart comes to a standstill beforehand or the patient becomes extremely unstable for a second apnea, would you be okay with going ahead and retrieving the organs through DCT? That's the time when we'll start engaging, because the decision-making process also takes time.
Sure.
I mean, everything
So-
takes
So I think let us talk about the consent later. Let us talk about the technical.
So we have three 16 gauge cannula in place.
3 16-gauge cannulas in all three, and we have left the patient alone. We have given 30,000 units of heparin. The attendants wait for 5 minutes. They go away. Immediately we start putting the guide wires through this. So 3 guide wires, 3 vessels. Okay, once the guide wire are in, then 23 gauge venous access line, and we're going to have a 18 gauge return arterial.
On the right side.
Both on the right side. Okay, so
Keep
this is how
opening
it
and
is.
showing. We will share the list of equipment that you need, 1, 2, 3, 4, 20, 30, everything.
So will be sharing the video.
So I will
I don't
sequentially
think so. You can be
dilate and rapidly insert the venous line.
But we can make some
The tip of the venous line is just beyond the hepatic vein. That's normally where we keep it, just beyond. Some people keep it at the level, some people keep it just beyond.
The venous one.
The venous one. Okay, this is 23 gauge.
Do you then have a CR?
No, we have an ultrasound which sees that we actually place the position on the side. We have placed the lines also on ultrasound guidance. So we can see the tip exactly where it's supposed to be. Okay. We put in the arterial line on the same side.
This will go up to your time.
Yeah, it'll just go up to that. That's about it. Okay.
So how much French?
This is around
17.
17 French. This is 17 French, 23 French. But there's a range.
All patients alike is a 19 arterial, 25.
25.
Okay, so 19 arterial, 25 venous.
The reason why 25 venous is it's a passive flow, right? So the larger the bore, the better the flow.
Low volume.
It's a low volume flow. Larger the bore, the better the flow. Okay, the arterial is an active push, so you can have a smaller range kind of. That's not a problem. So from here, we're going to be inserting this. We have already seen the measurement from here to say, like the way we measure.
Correct.
Right? For an IVP also we measure to the sternum notch. So you can measure to that level, that will be around the mid-thoracic level. Correct. Right? And you insert it through the sheath.
Okay.
And inflate it. Inflation.
Vascular surgery team, Manipal.
So this
So
balloon.
this is a Reliance balloon. It has
So just holding it so that you can see this balloon is inflated up.
It's enough.
So this should be enough for the aperture. And we're going to be inflating it with omnipeak. So we can see it.
See it
on
on
a
the CR.
CR. But that's just for a confirmation. That's not going to stop our procedure. Right? We don't wait for the CR and come in. It won't be a CR here because the beds don't allow for a CR. So it's going to be an X-ray. Right?
Just to confirm.
That's just to confirm.
Yeah, come forward. What you can go slow, huh?
With thoracic level.
So you also have to check that there's an arterial line above.
Yes, so that how you
Correct.
What
Left, right,
he says is
doesn't
that most of the patients usually have an A-line in situ. So there's no flow in the arterial. It says that once the circuit has started, there's no trace in the arterial. That means there's no flow which is coming into the thoracic. Okay. Direct way of confirming this.
So for people who are not familiar, we are going to start a circulation with femoral artery and vein, and we don't want the blood going up to the thorax. So we are inflating a balloon in the abdominal aorta from the suprarenal on the contralateral side, so that there is no flow above. So the flow is in the liver, kidney and the pancreas, right? Yes. Now the question is about how much to inflate. So I was talking to the vascular surgeon. He says don't do a fixed volume. So what happens is this takes the shape of the aorta. So as we are inflating, they do it under fluoro. So as they are inflating, it takes a sausage shape, the shape of the aorta from the round shape. And when they feel that it is a nice sausage, that is the size to stop. Don't do a fixed volume. That is the recommendation from the vascular surgeon. Now how do we do that with X-rays? We'll have to work it out. We do about 25 ml and then see. So with practice we'll get to know that. But the practical important thing is that the balloon should become the shape of the aorta, then you know it is holding it nicely. And Dr. Komud was talking about having a radial artery in place, because how will you know that there is no flow in the upper part of the body is that the radial artery would become flat. So that is how you make out that there is no flow happening in the
Your balloon is at the right.
Yes.
Yeah.
That we said that the air balloon has to be suprarenal. It should not be supra. It's a bit thoracic. Correct. Not suprarenal.
Supradiaphragmatic.
Supradiaphragmatic, mid thoracic. Not suprarenal.
Sorry, yeah, I mean, yeah.
So now, once these cannulas are in situ, we are going to be attaching the blue venous one to this venous one. From here, the blood is drawn. Okay, it goes into the reservoir. Right. And remember, this side is a passive flow. There's no pump which is or suction which is pulling.
Can you connect it?
Sorry, it's already connected.
No, but I'm making this side.
Can you connect this side also?
So we can do that. We'll have to open this and then we'll have to connect it. What he's actually saying is that when we have the blood coming out, there's some air here, and as soon as we connect it, there's fluid inside this tubing.
True.
So there's a small column of air here. So we don't want to just push that. So somebody will be just pushing in saline from the top, and we just sort of attach both of them together.
So for an ECMO person, this would be a routine.
It's a routine.
It is. So now you remove the clamps and then you're ready to go.
And once we do that, they just remove the clamp and allow the flow to go inside. Okay. So now what happens to the flow? Let me just talk about it. So what is the modification in the ECMO machine that we have done? So this comes here, goes to a reservoir.
Can you show the reservoir?
No, reservoir is not a part of a standard ECMO circuit. Okay. This is a CPP reservoir. It's kept here. Now, in case I don't get a very great flow, for whatever reasons, there is a backup facility of attaching some negative suction also.
To pull it.
To pull it. This can give low volume suction also to pull it. Okay. This is a add-on kind of a thing which you can use. Some people use the wall-mounted one, but the pressures can be extremely high, so we do not try to do that. And this is only the case where the flow has not come.
Where is the suction attached to which part of the
Here. It's already attached. It's already. This is a closed kind of. This is a closed container. So it's just applying a low level of suction just to drop. This was not what I had said, but this is something which can add on. Okay, so from the reservoir, you can see this one is going into the pump. Till here is all passive. Now the pump is the one which propels the blood forward. From the pump, it's coming into the oxygenator, which is attached.
Just show us, if you don't mind,
The oxygenator.
arterial one way into that pump.
Yeah, you can see here.
No, this arterial fuel which you have.
This one.
This is venous.
Just trace it down.
Okay.
Arterial one.
Okay.
Arterial one is this one.
Yeah.
Detach the cone.
Yeah, sure, sorry.
Okay, so from here it's going.
Just detach the cone.
From here it's going.
No, just take the cone out.
Just for us to know exactly.
So it's at right angles.
Yes, this is
So inflow
out.
pumps out at that right angle.
See it?
Right.
Inflow, outflow. Okay. So outflow is going into the oxygenator, which has an attachment.
So the
for-
patient's blood has flown into the reservoir.
Yes, his blood has flown into the reservoir. Okay.
And-
From there, it has gone into.
What is the volume of this reservoir?
How much blood you want to come into the reservoir before he pumps?
4 liters of volume of the pump. You don't need a 4 liter pump.
Correct.
You need not just 1.5 to 2 liters as well.
The reservoir is primed already.
It's already
Blood, right?
So just tell them that.
Primed with Hartmann's amount of, a certain amount of 4 units of blood typically,
You can
right?
do that.
Now,
Already primed.
if I can just add
So how much
one,
blood we need in the reservoir before we start?
typically it's about 4 units. Now, depending on whether hearts are being taken or not, you don't have such.
So right now we're doing just abdominal.
Yeah.
So how much
But
do you
even
recommend
so-
for abdominal?
I just want to point out that even in this situation, because we now have circulatory death established, you can still do abdominal NRP and not exclude heart and lungs being utilized. So I would just want to add the little complication we're now explaining everything, that this venous return, as you can see, when machine perfusion requires a donor blood for the prime, like the heart would, this is where you would put a white connector. You just clamp that, and now you have this already a pre-primed circuit. When you're using the heart, donor blood, hemoglobin must be 10 or over, which you've already put into the donor. And then the rest is primed here, so that you don't entrain any air as you run the pump.
So minimum 4 units of blood you would
And
need.
Hartmann's. And
Plus Hartmann.
Yeah, we have that in the protocol.
So we are publishing all this for everyone to read. Okay.
That's for the heart when we are talking about.
Can you tell
Okay,
me
when the heart is not to be used, only
Then
the
you, don't,
liver and
then you do not
kidneys.
need the
You don't
wine.
need the wine.
You just carry on as it's been
As
described.
it's been described.
Yes.
Okay, so you can have some amount of foreign hemoglobin, you can have a dilution also, that's not a problem.
Correct, not a
Okay, so that's not a problem at all.
Can you just tell us a little
Can
bit
come down
about-
all the way till 6.
Tell us a little bit about your reservoir.
Yeah, so the reservoir is just to sort of get some kind of a flow going. See, 1.5 to 2 liters, we just need to get that forward flow from here to there, so the pump can push it forward.
So is this a reservoir with the cardiology,
Yes.
We'll just pause for a second, ladies and gentlemen. Welcome, sir. We have Director Notter here, so welcome, sir. Yeah, thank you very much. So we just started the demonstration, and we have reached the stage where both on the left, the right side, the femoral arterial vein has been cannulated, on the left also. And now we are talking about getting the blood from here into the reservoir, which is usually not a part of the ECMO machine. So why we call it a hybrid system is because we have attached a reservoir for the purpose of NRP. So this reservoir is what he is telling us about.
So this reservoir is sort of creating a pressure, right, to push the blood through to the pump, and that pump takes it to the oxygen. The pump onwards is a positive kind of a flow, and it's sending the blood forward. So this pump also has an attachment to the blender and a heating. So you're going to warm it. You're going to warm it to 37 degrees. That's going to happen here at this level. And this blood is finally out of this, comes back through the artery, into the circuit, into the system.
So this reservoir is a very important part of this because Ravi, a few attempts at doing a NRP were made and people didn't know that a reservoir is needed. So
Air into the system.
and then it doesn't work. So
No, the pressure head to push it forward is not existing. That's all.
Second thing is that, when you are doing an abdominal only NRP, which is what we are describing now, you need lower flows compared to when you are doing a thoraco-abdominal NRP, which will be next described.
So we're going to fix
So how much is the flow for-
1.5 liters.
About 1.7 to 3
1.5
liters.
to 2 liters should
For
do the job.
abdominal NRP alone. For the chest included, it will be around 3 to 5 liters.
You blend around say 50% and say around 2 liters or so.
So हमारे साथ राकेश हैं जो हमारे परफ्यूजनिस्ट हैं और ये फ्रॉम द CTVS टीम, तो इनका यहाँ पे होना विल बी वेरी इंपॉर्टेंट बिकॉज जब भी ECMO मशीन चलाते हैं ये हेल्प करते हैं, तो इस प्रोग्राम में CTVS एंड राकेश आपको इसके बारे में थोड़ा सा कुछ और कहना है?
Yeah, it is a very important role in the reservoir because Fresh told always the some air is stuck to some drain in the reservoir.
हिंदी में बता दो।
So जो भी एयर आता है वो एयर को हम इसके अंदर एयर रहेगा और इसके बाद ब्लड केवल ब्लड ही जा सकता है. अगर आप इसको कट ऑफ करेंगे तो इन इक्मो द सम एयर सक and direct into the goes to the patient. So this is the important role of reservoir.
एक चीज पूछनी थी आपसे, ECMO में रिजर्वायर नहीं होता?
नहीं,
Normal ECMO
नहीं होता, नहीं।
वहाँ कोई रिस्क नहीं है एयर का?
होता है.
बताइए उसके बारे में। ECMO में कैसे?
जब पेशेंट हाइपोवोलिक होता है या फिर सम काइंड ऑफ ब्लीडिंग्स, सो उस समय हमें एयर आने का, एयर सक होने का खतरा बहुत ज़्यादा होता है. और दूसरी चीज़, अगर हमारे फ्लोज बहुत ज़्यादा है और पेशेंट वॉल्यूम कम है तो उस समय भी हमें सक होने का खतरा होता है. लेकिन जो ऑक्सीनेटर आता है उसके अंदर एक सिस्टम होता है कि वो 40 ml एयर सक रख सकता है और उसके बाद में उसमें एक वैक्यूम पोर्ट होता है. वो वैक्यूम पोर्ट उस एयर को, केवल एयर को बाहर निकालता है, ना कि ब्लड को.
दूसरा एक जो सवाल मेरे मन में आ रहा है कि ECMO में हमें रिजर्वायर की जरूरत नहीं है क्योंकि हार्ट एक्ट कर रहा है रिजर्वायर. So is heart acting like a reservoir in ECMO or in what way?
So it is
Body is a reservoir. Body is a reservoir.
Okay, so it is the gravity is
इसमें आपने हटा दिया.
the gravity coming out and just going through the entire system. So there the heart is pumping, the circulation is ongoing, so there's no need for this kind of things to be done. This, see, the air is going to come up anyhow. Any fluid air collection, the air will come up, the fluid will be on the bottom. So the outlet is at the bottom, so only the fluid part comes out.
So we have collected and now we are pumping warm and oxygenated blood back into the
Patient.
Now, because we have a perfusionist, I think it's important to state how important this role is. It is absolutely crucial for a number of reasons. One, they are the people who are telling you every 5 minutes from knife to skin or whatever you started the NRP, the timing The other really crucial thing is in regard to that reservoir, particularly when you're doing thoracoabdominal full body perfusion, because the level of the reservoir of the fluid is critical based on what you're flowing in terms of liters per minute. And unless you have a flow sensor, you will get very little, few seconds only before that reservoir empties and is full of air. So they're critically watching that.
Yeah.
But ideally you should also have a level sensor to be protected. Because at 3 liters of flow, and the reservoir, let's say, has a liter in there, at that rate of flow, you have about 20 seconds of thinking and acting time. The moment that reservoir goes to 200 mils, you have now about 4 seconds.
Wow. So, हमारे in the people who have joined consortium के हमारे NRP के national के कुछ और भी लोग होंगे. Is anybody else there? Giovanna, is Kalai there?
I can't see Kalai online, sir.
All right. So he is the one who is also one of our perfusionists who has been helping. So, any comments from the audience?
Can I ask one question?
You have a pump there, no?
Yes.
What is the pump?
That's it.
Size,
What is the role of this pump?
the size of
The
reservoir.
role of
So that also helps in
to take the volume, the reservoir, and push the volume of fluid to the patient.
The size of the reservoir will vary. The size of the reservoir will vary, obviously, with the size of the patient.
Yes.
Because this is about 4.5 liters, you said.
Correct.
This is 5 liters.
We would normally fit that with the size of the patient, whether it's pediatric adult. But in our context, we should just stick to the same kind of reservoir, recommend the same
So
one.
even if it's a pediatric,
No, no,
then you change it.
that'd be different. But for adult setting, what I'm saying is, we should recommend a singular type of a modular system, knowing that jurisdictionally people can choose what they have. Now, for example, right now, there's a national crisis.
Yeah.
We do not have enough oxygenators for ECMOs right now. So we have to do your jugad and do whatever we can.
So this is about 4.5 liters, right? You said.
So we have Dr. Naresh here. He's our CTDS anesthesia person. आपके कुछ any comments?
One more thing is there is a difference between this centrifugal pump and roller pump. So this centrifugal pump are these are preload and afterload sensitive. So it's not like when there is a roller, when there is a mechanical roller pump, that will give at exactly, for example, if you are set it at 3 liters per minute, so it will pump it out. But these are pressure sensitive. So once the flow doesn't go, it will stop. So there is a inbuilt also mechanism that this pump will not run without the volume.
Okay.
Okay, I have one question to ask
Yes.
about this reservoirs. So are these standard things that are available everywhere?
What's the cost?
And what is the cost?
35.
ये जो आपकी ओटी में जो आप यूज करते हैं उस मशीन के हिस्सा है.
हाँ, हार्टलंग मशीन यूज करके उसमें रिजर्वायर ऑक्सीनेटर.
So every OT with CT based OT has a heart lung machine. It's a part of it.
The similar type of reservoirs.
In fact, we brought it from there.
I know, I'm asking a very silly question, but it's not reusable, obviously.
This is not reusable.
What Naresh is very important, by the way.
Now, can you repeat that?
Yes, so what Naresh also described about the difference between roller and this
Pulse.
is that that's why we go and our criteria is the pressure that we read, we adjust the flows to. So we're not getting just a fixed flow. I mean, that's just a guide as to roughly what flow you need. But it's the pressures we are maintaining and adjusting flow.
So, the patient NRP has been started and the blood is flowing, and the maximum duration that we can do this is about, say, 2 to 4 hours. So what do we have to now do over the next few minutes? Can we describe that? How we go about the next step? So would you like to just tell a little bit on that? How do we see that the liver is working well? How do we see the organs? What are the samples to be collected? Anything.
Somebody's describing when you take this patient to protein.
Yeah.
That's when.
I want him to just tell us a few. Now this patient was in ICU. This has been established. And this is a portable machine, so we can take him now to the OT. So now the next step, how do we monitor the various things?
The critical thing is to utilize organs. If the organs are not utilized, all this effort is wasted. So you have to establish that the organs are functioning when you re-establish the normothermic regional circulation. The kidneys may produce some urine. I normally never see more than 10 to 40 cc's over a period of an hour or 2 hours. But the critical thing is the liver. And the number one consideration of the liver is whether it's clearing lactate. Usually if you prime with blood, there will be a high initial lactate. I like to prime with blood if the hemoglobin is 10 grams or less. Because sometimes some surgeons who are accepting the liver will say that your hemoglobin dropped too low, and so they are not certain the oxygenation delivery was adequate enough. So in order to satisfy them, we like to keep the hemoglobin around 10.
So you will not necessary that we prime with blood, is it?
You don't have to prime with blood. Once you prime with blood, your initial lactate is going to be high. Not a problem. Because your liver will clear it. And generally speaking, within an hour, the lactate will drop to 50%. If your lactate is dropping to 50%, your liver is working. If you are doing laparotomy also, you can do a biopsy of the liver. So you have two parameters to decide whether this liver is going to work or not. And once you know that the liver is going to work and you place it with these two parameters, they always work.
So Dr. Philip, in DVD, usually lactates are normal. Like if it is properly managed, then the lactates are somewhere around 0.8, 1.2, 1.5 like that. So how much do you anticipate, like you must have seen, how much, when you said ki when you prime then the lactates increase. So what is that value actually?
The question is when a patient's brain dead, they're being managed in the ICU by very expert people, and the liver is clearing lactate, so when the patient comes to the OR, the lactate is normal below 3, maybe even as low as 0.8.
Exactly.
When you go to DCD, the level of lactate rise depends on the agonal time, or what is called a functional warm ischemia time. Now the problem is many centers will say they will not accept the liver if the functional warm ischemia time is more than, let's say, 30 minutes. Okay? Now this is a problem because I'm twice your age. If we both go to withdrawal of life support, whose heart will beat longer? Your heart will beat longer. So with you, the functional warm ischemia time will be more than it will be with me.
Right.
But your organ is likely to work better than mine. So this is a paradox. Bottom line is the longer the functional warm ischemia, the higher is going to be your lactate. But the clearance of lactate will be better with you than with me, and that will be the deciding factor. The initial lactate I have seen between 6 to 14.
Yeah, this was what I was.
And when it clears, within an hour you will be 50% of that.
Okay.
So do we have in the audience, is Darius there or Chris there, anybody from UK or anybody from Spain? Okay, so they haven't yet joined. So what about the role of AST and ALT? Can you specify that?
The only reason to do an AST ALT is in the recipient. It becomes your baseline, to which you compare how the recipient liver, how the liver is working in the recipient. So if your AST ALT were 1000 and in the recipient it is 2000, that means your rise is only of 1000. You see? So it helps you to monitor function in the recipient, but it is not a criterion for acceptance of the liver.
I want to ask you a question. I mean, again, from distance. You said 4 units of blood, right? Initially, for this one.
Sir, we keep 8 units in the OR. Okay. When we go to the WLSD or we go to a DCD program, we ask for 8 units, PRBCs. Now that you may not need to use it all, but you have to have that.
No, but this is why you said, you know, to prime.
So when you prime it, you have to decide whether to prime with crystalloid, colloid, blood.
Right. Okay.
Generally speaking, every center or every perfusionist will have his preference of the prime.
Right, okay.
You can ask them to include blood if you are starting hemoglobin in the recipient's ICU labs is low.
So we have to maintain around 10.
Only for the heart.
आपको प्राइम करने में कितना टाइम लगता है?
For abdominal organs, you do not need a certain hemoglobin. Only for the heart, people expect it to be more than 10.
Correct.
And if the hemoglobin is 5,
You don't need to time with blood into abdominal.
6 or 7.
so we have to specify hemoglobin.
So let's say 7.
7.
Okay. So 10.
That varies from center to center.
Yeah, center to center.
The protocols that are in the document.
So we have written in our guidelines that hematocrit should be around 20.
Which is perfect.
Yes, right. At least 20 hematocrit per
That we know which you get.
So that is hemoglobin of 6 or 7.
Yeah, 6, 7, 6, 7.
Old, lactate, high, old, doesn't matter.
It does matter.
I didn't get the question.
Lactate.
It doesn't matter what kind of 8 units, is it could be fresh, it could be old will have high lactate, does it all matter?
Blood.
So when you give blood, the lactate is going to go up because of the blood.
And this is a
The problem is, if you have to give blood, you spend 2 hours, you're running this.
So you had given 30,000 to skip.
So now can we switch to a thoracoabdominal approach because we don't have too much time? And
How much time does it take for blood to breathe into the reservoir and to pump it back into
Minutes.
to start the perfusion?
Seconds.
What about the perfusion of organs during that?
So it's minutes, seconds. It doesn't matter.
It has to be how much?
So typically it has to be for accepting a liver from the time you withdraw, from the time the patient becomes asystolic or circulatory failure. If it's more than 20 minutes or some centers use up to 30 minutes, then people may or may not use the liver. If it's less than that, then it's not a problem. So this additional 15 seconds or 30 seconds when the circuit is going to start is going to add into this 20-30 minutes, won't be a problem.
So basically 5 minutes of
Function obviously,
okay,
not more
is
than
the
5
video off? They're not seeing the video.
Yes.
Probably can be on that side.
Let us know if you don't. Actually, if we talk, then nobody will be able to understand. You cannot see the video. Please tell people to stream again.
We will be
Okay, what
talking
we'll do
about.
is we have 4 hours to discuss all this and only 15 minutes more to go.
Yeah, I think technical parts we should
Yeah,
do.
so let's, the theory part we can discuss. We have talks on all this. So I'll request Kumud to now step in and tell us that now we want to retrieve the lung and the heart also. How do we do a thoracoabdominal NRP? If you can just tell. Yeah.
Sure. So
Can you
the
hear us?
thoracoabdominal part is not very different in terms of the actual connections to the circuit. The circuit will remain the same. It's just that you're approaching through a medium sternotomy.
You want to-
The central vessels, I mean, it's okay. So normally what you would do is do a
Recording in progress.
sternal notch all the way down to the pubis incision, right? So that both teams are there. And you would then open the pericardium, you would retractors in, and you would do several steps. One is to put a 2-stage cannula, which I don't know if we have, but it's a slightly different from this thing. It's a much bigger cannula that you put through the right atrial appendage that has some holes that sit in the right atrium, and the rest goes into the IVC. That allows you to get very good drainage into that reservoir and the pump, and you return it via cannula that you place in the ascending aorta. Now, before you start that pump and perfusion, you have to exclude any blood going to the brain on these protocols. And therefore, you must identify the 3 brachiocephalic arteries and put a clamp across them. Only then can you start the clamp, right? The pump. Now, then you essentially are what we would normally do in a cardiac case, which is to go on cardiopulmonary bypass, except we've got a hybrid system here, but you could just as well have a normal
just go to the
cardiopulmonary
OP
bypass.
after this.
Yes. And then you run that to a point where you're now happy based, you're running that on flows that determine a certain degree of pressure, mean pressure of at least 60. And what you're trying to do then is when you're happy, abdominal team's also happy, then you will wean, because the heart will reanimate. And you will then wean the flow and to 0 and try and reduce inotropes, right? And you will do that for up to a period of 20 minutes to assess it. Don't forget, if we're taking heart, then we will have a transesophageal echocardiogram. You'll be seeing it palpably. You can examine the heart and everything else. And what you've done is just simply converted a DCD into like a DBD scenario, except for the head and neck vessel clamp, which is the only difference. And then once you're happy, then obviously you do exactly the same steps as you would do now in your DVD situation.
So this is the cannula that's going into the aorta, and this is the cannula going into the right atrium, through the right atrium into the IVC. So basically it's exactly the same that we did here. There is no need for a balloon or a rebova. There is just two cannula, one going into the aorta to push blood into the aorta. It will circulate all the organs, and then all the return is going to be through the right atrium through this cannula.
So which part of aorta?
Ascending aorta.
This is in the OT. So now we'll all be moving to OT and showing you the heart lung machine that is used.
Just know this catheter
Yes.
will go through right atrium. into-
Right atrial appendage,
Ah.
and it goes in, you direct it into the IVC.
Okay.
It is designed in such a manner that some of the holes will remain in the right atrium, therefore draining upper body blood, venous blood, and the tip will go into the IVC,
where we are getting
draining lower body. Now, just to move on, so now I must just like to describe when you're doing abdominal NRP, what happens in the chest, right?
Can you open it?
So this is a two-stage cannula, you can see, which has much bigger, and it has this hole over the blue area, which is going to sit inside the right atrium, and this tip part here beyond the wire reinforced element that sits into the IVC.
Right. So this will stay here, and this is the aortic
This is
cannula.
the aortic
typically it will
cannula.
stay like
It's
this.
like typically a 24 French cannula, which will sit
Into
there,
the
right?
which part?
Ascending aorta.
Ascending aorta.
Because you're using the heart, it must be, you must have enough donor aorta to do your recipient anastomosis. So high up into the ascending aorta or even proximal arch.
And all the three brachiocephalic arteries need to be clamped.
Clamped. And it is critical that that clamp does not then end up clamping partially or fully the descending aorta, because you just turned it into a disaster by doing that.
Yes. Also, you would like to clamp the aorta low down so that there is no flow in the limbs.
No. So that is before we retrieve organs. Now, if we just go back one step to the peripheral scenario of abdominal NRP, where we are taking heart or and lungs, then you would do the median stenotomy. There's several really critical steps. One is that if you're taking the lungs, this patient would have been re-intubated, right, already. The first thing you do, almost from the bed coming in, is to re-intubate before you put it, because you can otherwise get contamination from gastric contaminants into the lungs, and that's a disaster, particularly when the guys in the abdomen start manipulating. So, if we're now taking the heart and lungs, then again, the clamp is critical. But more importantly is a vent in the aorta. So that ascending aorta, the same pipe that we put in here, is put there and left open. Because there should be no retrograde flow beyond that balloon. Now, if the balloon is not being utilized and we're doing this together, we would put a clamp on the descending aorta above the diaphragm. Which again means once you've done that, or the endoluminal balloon is effective, then no blood, or at least nothing oxygenated, is going to come up this tube. If there's flow coming up here, we have to stop. Or if the heart starts to beat, in the absence of us giving perfusion antegrade, then we have to stop, because there's an issue, right? And then you can proceed. Yep. And for the heart and the lungs, you need to put a vent in the pulmonary artery. Again, the same cannula that we would use to give the pneumoplegia in.
So now
again, left open to vent, so there's no acute pulmonary hypertension.
So we have only 10 minutes for the OT.
Yeah, sorry.
So we'll talk while we are going, but one last comment.
Is that when you, for the lungs, when you re-intubate and all this other thing is going on, one of your team members can do the bronchoscope, do bronchial toileting and so on. And that can be repeated when all these abdominal assessments are going on.
Okay, let's go to the OT now with the camera. We'll see you soon, everybody.
हार्ट और लंग्स की तरह काम करती है. सो सब कुछ स्टैंडर्ड है, बट ये होता है एक वीनस ड्रेनेज. ये पेशेंट से हम वीनस ब्लड लेंगे और वीनस ब्लड लेंगे. इसके बाद में ये वीनस ब्लड रिजर्वायर में कलेक्ट होगा. देन द पंप रन होगा लाइक दिस, एंटी क्लॉक. यहाँ से पेशेंट पंप में आएगा, ब्लड पंप के अंदर आएगा. देन पुश इनटू द ऑक्सीनेटर. ऑक्सीनेटर के अंदर ऑक्सीजन मिक्स होगा. ओके, ऑक्सीजन मिक्स होने के बाद में सेम थिंग्स वापस ब्लड पेशेंट के पास।
तो अभी हमने जो आईसीयू में देखा दैट वाज एक्मो बेस्ड विद द रिजर्वॉयर, और ये हमारा जो मशीन है ओटी में, सो व्हाट इज द कॉस्ट डिफरेंस व्हेन वी यूज एन एक्मो मशीन रिजर्वॉयर के साथ और जो आपकी हार्ट लंग मशीन है? अगर हमें 2 घंटे 4 घंटे के लिए एनआरपी चलाना है तो कितने पैसे में फ़र्क पड़ जाएगा?
अगर आप एक्मो के साथ लेना चाहते हैं तो 25 to 30,000 सेंट्रीफ्यूगल पंप जो हम यूज़ कर रहे हैं वो कास्ट कट ऑफ हो जाएगा अगर हम हार्ट लंग मशीन पर लेते हैं डायरेक्ट पेशेंट को।
तो ये सस्ता होगा?
ये सस्ता होगा।
तो इसका कॉस्ट हमने जो जुमना आयुध है, हेलो मेरे को सुन सकते हैं?
Yes, sir, I'm there.
So you had worked out for our paper that the cost of using a heart lung machine in the OT would be around 50,000 rupees?
Yes, so it is 50,000 cheaper than the ECMO cost because the ECMO machine, like you said, we need to use an extra pump, which is the pump head, which is not required in a heart lung machine.
जिसको आप लोग कोर बोलते हैं।
We are using the same, we are using the same oxygenator and reservoir, so that this is the same cost. The cannula are again different. The cannula we are using in direct cannulation of the vessels post-laparotomy or post-anatomy. Our combined they come up to not more than 20,000, while the ones which we use for ECMO will be around 50 to 60,000.
So ECMO के जो कैनुले हैं वो 50,000 rupees
या ईच कैनुला,
हाँ,
50,000 ईच कैनुला।
So cannula का cost is more and we have the cone which is more.
Yeah.
And also we have the balloon that we need in the ICU which we don't need in the OT. So from about 50,000 it increases to about 1 lakh, 1,20,000. Almost double, right?
1.5 to 2 lakh.
Yeah. So 50,000 is quite affordable because it will be shared by the recipients. So Dr. Kumar?
There's another cost we haven't factored in, and you'll notice the difference between the ECMO circuit we saw and this heart lung machine is that here you can see several pumps rolling. These are roller pumps. Okay, on the ECMO you only had one tone that was working, which means what do you do with the bleeding? So when you're dissecting the chest, abdomen, there may be bleeding. So in the ECMO, the only way you can get that back is you have a separate cell saver from which you can salvage and do it that way, and therefore incur the cost of disposal of the cell saver. Or you need to have one of these modular roller pumps to be able to attach to that ECMO circuit, so you can use that as a sucker that then blood goes into the reservoir. While this already comes with multiple roller pumps, so that the blood that is lost can be salvaged and put back into this reservoir.
Sir,
Thank you. So,
out of these two
question. The question is ECMO with the reservoir, the hybrid system better? And when we mean better cost, we have already said. Now you want to know what is better in what way?
quality of organs that will change and the cost also.
So quality of organs will be same because we are just giving the exact same circulation. But the main two things is one is cost and two is portability. So this is more portable, cheaper, but requires the whole process to be done in the ward. That one is more portable and requires cell saver also, so that additional cost may be around.
So the heart lung machine is not portable. Heart lung machine can be used only in the OT.
So if we have a chance, we should try to shift the patient to OT and
So now, Dr. Philip, the question asked is, if we have a chance, should we do this whole process of withdrawal support in the OT, or we start in the ICU and then shift to OT? Because if we shift to OT, what are the advantages besides the cost?
Shifting to the OT is the only thing I've done.
Correct. Tell us.
I would not want to go to a hospital, especially many of these DCDs are in small hospitals, where sometimes I've not even had a sternal saw to open the chest, open the sternum. So starting all this outside the operating room is extremely hazardous, and anything goes wrong, people in the US are so risk averse, they will not accept the organs. So the most stable situation is bring the patient to the OR, DCD3 type, set up everything, let the family members be sitting with the patient. When the arterial waveform flatlines, they are escorted out 5 minutes later, death is declared and we start the NRP.
So, since we have not done withdrawal of support much in our country, Dr. Shroff, Dr. Mathur, all the seniors here, Dr. Noto is here, we feel that DCD4 should happen maybe tomorrow, where a brain dead person is unstable, and Dr. Shrikant, where are you? Dr. Shrikant in the ICU here, he is going to do it in the ICU, the part that we've shown you in the ICU there. And only once we are ready for the organ retrieval, we are shifting that patient on ECMO. We have used it in the elevator also, that ECMO machine. We have been taking people for CT scan on ECMO. So that is extremely portable, and we can move to the OT and then do the rest. So both scenarios we have to be ready for. But withdrawal of support, when we do DCD type 3, then most definitely OT would be the preferred. But we have to be ready for both.
I want to ask this ECMO, you said that the pump is the extra cost. So is it a disposable pump or is that's why it's an extra cost?
Yeah.
It's not one time.
The head is disposable.
It's about 30,000 rupees.
Yeah.
And the word they use is cone.
Yeah.
We have to get used to all these terms.
So the cost of cone, tubings and potentially cell saver. These are the three added costs. So it will go to 1.5 to 2 lakhs.
Thank you. So,
And balloon.
balloon of course we are using only in the ICU. Once you are in the OT,
That is also additional.
once you are in the OT, you can open and clamp your aorta.
And do we need to use cell saver in every case?
No.
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 Yes,
Yes.
every time. You have to be ready for it. If you start bleeding, that blood cannot go into the trash suction. You have to save the blood.
Also, what you have to be ready for is a super rapid recovery. If you are unable to establish your flow as we are starting, then at least go for the super rapid recovery and do what
Save
you
the
can.
kidneys.
That's why I like what you say is that do the classic approach. So your sternotomy is already done, your organs are already seen. What do you say?
But you can only do it in type 3. You can't do it in type 4.
No.
Yeah.
And I feel that balloon thing is difficult to do in ICU.
Yes.
Without a fluoroscopy.
Okay, now we are running short of time. We can have discussion. I'm going to show you how Dr. Meena, every sister on the ICU. So we are saying that we need a record of what happened when we withdraw support. How when we have a flat line that it was there for 5 minutes. So we need some kind of proof that whatever was there has been adhered to. So every machine, a monitor has trends. So we have set this trend so that every 5 minutes everything is recorded. You can make it 3 minutes, you can make it 1 minute. But as what we would recommend, Ravi, what we would recommend all of us to the country when we start this is that we set the trend as 5 minutes. Is it okay?
5 minutes is okay.
5 minutes?
Yes.
And then आप एक बार दिखा सकते हैं कि कैसे होता है ये?
हर 5 मिनट में इसका शो करेगा कि इसका हार्ट
जोर से बोलो।
रेट, इसका हार्ट रेट पल्स हार्ट रेट और
Arterial systolic, diastolic, median,
टेम्परेचर
जो Wonderful. So
एवरी 5 मिनट्स का देना.
now the important thing is कि once we do the next patient, all this is erased. So एक बार ये सब हो गया, so somebody has to take a camera and take pictures of the relevant time periods, which we should also specify in our manuscript. These are the minimum pictures that we should take and record.
Some of these come with printers.
That is correct, but some also have a memory
It has a
stored.
memory. So some of them come with memory store and printer. So if there's a printer attached, you can take a printout.
Yes, at the end of the case,
In many
attach it to the
places in our country, we don't have printers with every monitor.
Yes.
So in that case, of course, you can take a picture.
We are doing pictures in US, Philip. In US, we are doing taking pictures. No.
Yes, because there will be several teams. There will be several teams waiting in the lounge, the doctor's lounge area or in an adjacent operating room, and everybody wants the trends. So the coordinator takes the pictures and sends it in an SMS message to all the surgeons, cardiac, lung, liver.
So the important point is that the surgeons are not allowed in the room till there is a 5-minute flat line.
Yes.
So that also is very important.
So just to point out, I think one of the big differences between Philip's practice and mine, or more European style or Australian practice, is that in the US you're more likely to have the withdrawal taking place in the same theater as the retrieval. Am I correct? Right? So elsewhere, the withdrawal is happening in an adjacent theater because the retrieval surgical teams are next door, already prepped and gloved, ready with all their trolleys to receive the patient from the next door once that certification of death has happened. Now, the other place that can potentially happen is obviously ICU, then the patient is rushed in, or the recovery area from which they're rushed in, because different jurisdictions will have a different acceptance of where it is culturally or from an information point of view understanding where the family can go.
So you mean to say in your the family can be catered?
Yes.
That's right. I mean,
It has to be timely, that's 5 minute, whatever, or milestone directed communication so they know exactly what's happening with the trends.
Thank you. So we'll take a break now and join after lunch at 2 o'clock sharp. Let's take a break. Thank you very much. Thank you, Dr. Beena, for chairpersons. Now, out of the chairpersons, one is virtual, one is here. So the person who's here will come here because then you'll be visible to everybody on this chair. And what I'll do is I'll say a few words on the first chairperson. The other one will be missing. And the chairperson who's physically present can introduce this and then try to say a few words. And I think sorry?
The one that's printed out the CVs of these people? No,
not printed out, they've been sent to WhatsApp. 3 people who have to introduce, है ना sir? Dr. Kumar has to introduce Eduardo.
Yeah, correct.
Has anybody met Eduardo?
I may have done years ago at ICHLT, but I don't
He's
remember.
from Spain.
He is a guy who's done.
He came for Deepak Mittal.
Yeah, he's there for most of the meetings international, and the guy should start NRP in a way. So when you start reaching out to him through Marty and other people, they say no, he will not respond to anything. But the moment we sent him a mail, and I wrote to him that we have heard you so many times, and I attended your course also. So promptly he replied, and he is the one.
Good.
Still, I was advised by Marty and a few people to have a backup speaker because he's that maverick, you could say. It'll be fun to have him here. Almost sound like Bob Dylan, right? I'm not coming. Because we haven't done NRP in India as of now. So we look forward to this session. Yeah?
Improving, yes.
Okay. So whoever speaks, I think, can hold this in their hand. That may be better. Yeah? Anything else? You can see us well? Yeah. Will that be better?
It's better you can stand there
So
also.
whoever can done it. Right. India does about 20,000 organ transplants in a year, and we are third in the world after US and China. And now with brain death being declared more and more, we have almost 100 organ donors every month. And this has been possible because of almost 22 decades of effort by stalwarts, some of whom are sitting here. Dr. Anil Kumar, Director Notto, very warm welcome to you, sir. Can you focus the camera somehow, or you can wave, sir? Dr. Anil Kumar, Director of our national program, thank you for being here. Dr. Mathur, Dr. Shroff, this side. Yeah. But now we need to move towards DCD, and about 30 of us have been working for a few years on this. We published 2 guidelines, one in 20 of all organs. We thought that NRP was the way forward. So we have a national consortium of experts, and we have been working on this. So a part of our consortium is our expert, Philip. Thank you, Philip, for being here. I don't know how many of you have met him earlier. Philip is based in Texas. Philip and I are from the same college, Armed Forces Medical College and PGI Chandigarh, and we have met as a consortium of 11 times so far, and he would be
Okay, sir. Sir, सामने
we need the seniors to light the lamp of knowledge.
Thank you, sir.
Mathur sir. Philip, come please. Philip. Pramod, come please. So DCD is going to be tough, is it? Come. We'll have a group picture. One more to like.
The role of intensivist is
Yes. Thank you, everybody. Now we'll have a group picture.
That's why he gets the last say.
Smile.
Thank you. Thank you. All right. Thank you, everybody. Dr. Azil, a few words.
By all the stalwarts are there, and we have experts online available, and definitely we look forward to a new basically way of generating our because now we have in our society the awareness is increasing. People are coming forward for donation, and many times because of the many situations like that, or because of the patient not going into the brainstem death stage, these situations we are not able to help them with donation. Families are now demanding donation, so that is also one demand for donation from the family side, their rights, because they are realizing that it is their right to be asked for donation. So, and as a government has to provide a system to help them with donation. So, but we see this initiative as a way to have an alternative in for various situations where we can have option that to utilize the donated organs. So definitely this DCD with Nrp perfusion that we are trying to understand and trying to implement in the country, and all our experts which are involved, and they have been working so hard for this to be implemented in a very ethical and legal way in the hospitals, and the entire group is working for I think quite some time, more than about a year, about 2 years, and we have drafted good guidelines also, and we hope that these guidelines will pave the way for increasing donations in the country and help those who are waiting for these vital organs. And definitely the aim remains that when we are implementing any such guidelines, the organ should be able to be utilized, and organs we should be able to get good organs. So that is the real aim when we are implementing these guidelines, that the hospital should follow a protocol where they are able to salvage the maximum organs, good quality organs, which can be accepted by the recipients and their hospitals. So that is the aim, and all these meetings, the discussions which have been going on for a long time, they are aiming towards that, and we hope to have because legally in our country, donation after cardiac death is allowed or circulatory death is allowed, and we don't see any problem in implementation of the protocols that have been worked out, and only with the support and practical aspects that our hospitals and experts are trying, like now have really understood well, we hope to take it forward, like implementing one by one, step by step, like to, as you know, we really don't want anything to be done which is perceived as unethical or which is perceived by the families, because we have a very sensitive society and we don't want that kind of any kind of whether to have any legal roadblock or any ethical roadblock, because we are moving very cautiously and definitely, and but we want donors, but donor numbers need to improve. We have a lot of requirements, huge requirements, and this is donation after circulatory that we see as a a big opportunity for the country to increase the pool of donations, and that we definitely looking forward to, and thanks to all the experts who have joined and taken forward this initiative. Thank you.
Thank you, Dr. Anil. Ms. Viji has joined. She is the hospital director for us, and all this is not possible without the complete support of the organization. And we have 37 Manipal hospitals, and we are trying to establish best practices in organ donation in all of them. And I'll request Ms. Viji to say a few words.
Good afternoon all. It's really a privilege and it's an honor for Manipal Hospital Dwarka to host this consortium. And because we believe in organ transplant as a noble cause, and chaired by with our chairperson, we have a specific program which is managed by Dr. Amish Seth, that is called MOST, where the entire Manipal group is working towards creating awareness and also promoting organ donation program. And like sir, we just mentioned about this new approach, or maybe this is something which is already there, but it is important that more and more awareness is brought into this, and I'm sure this consortium will bring in that. It provides a platform to enable discussions on how to implement donation after circulatory death, and this initiative and this dialogues which are going to be presented today will initiate, it will be a catalyst to expand more and more the donor base and expand the donations, organ donations, which is the need of the country, and it is also considered to be the greatest gift. It is a gift of life, and we are very happy to be partnering this, and I'm sure this will be a beginning to bring in a change in the way the country looks at organ donation, and it will open up more opportunities also. And thank you so much for being here today. I'm sure this is a great initiative, and wish all the very best. And thank you so much.
I'll request you to just honor our chief guest with a little token. Just a little memento.
Thank you for being here today. It makes a lot of difference.
Thanks to the Manipal group for hosting this, and most basically taking this forward.
One picture. Marty is our second chairperson. Marty needs no.
Pleasure to be here with you online. We have been here several times, and the work that you do is excellent. And I congratulate you for this initiative. And I think from today we can have a good recommendations to improve in India the practice of practice of the DCD information. Thank you. And I'm happy to be together.
Bangalore, after receiving his training in the liver transplantation, multi-organ transplant from the Makkah of the liver transplant, that is Pittsburgh. under Professor Thomas's heart. And that time, while we were struggling to set up the process in Maharashtra, he was the one who was setting up the process and all. Sometime, I think, contemplating what he should do, and he came back again to India, and this time in Kerala he set up the liver transplantation program. Now currently, he is again in the US. He is with the University of Texas as a medical director, and his current focus is on DCD donation using the technology of NRP, and that's what is forte today. And I request Philip to start.
Thank you, Dr. Avnish. Thank you for all the work you're doing and heading up this important and very good surgeons who needed to go the next step in this business of transplant. So I moved to San Antonio to just do a few days per month of organ retrievals, and having studied the problem, studied the concept of normothermic regional perfusion, I thought I would start focusing on that. And from October of 2023 to about February of 2024, all that I did was talk to ethics people, talk to units that were doing transplant. People were not happy with this idea, they were suspicious, they didn't know whether it would work. There was a whole new industry of normothermic machine perfusion, which is ex vivo, which for some reason has turned its face against NRP, so dealing with industry can be daunting. But whatever it is, we made a start in February last year, and the program was so successful that by October they wanted me to become the medical director of the program. And so that's what I do now, but my main issue and focus is on normothermic regional perfusion. So, my objectives are to discuss this new era of donation after circulatory death. We may call it cardiac death, but in reality it is pulseless electrical activity, it is still death. So we only go by the arterial line to see when the arterial line flatlines, because that is the end of circulation, circulatory death. To get a good outline is critical to making this diagnosis. I would like to only discuss a few practical steps. Dr. Ravi and Dr. Avnish have all put together an extremely comprehensive document, and there will be everything that you ever wanted to know about DCD and NRP in that document. My focus today is just on being practical in just discussing what is practical. The most important things I feel are two. One is you have to have an intensivist in the ICU who will be a champion intensivist and promote DCD with planned withdrawal of life support, that is WLSC. The next thing I would like to discuss is a few details about surgery and basically how to organize expert surgical talent, because most consensus of opinion has been that this surgery should be done by people who are a little bit more senior, a little bit more able to absorb any negative fallout from mistakes or suboptimal organ function following DCD NRP. I'm not trying to say that only senior surgeons can be the experts, but once we have experts, we should identify them, bring them together, share their expertise, and regularly debrief the cases that are being done. So, just to put in context what is going on in the US, I think it's okay to discuss what's going on in the US because what happens there and what happens here in India are similar in a lot of ways, because it's a democracy, it's very much multicultural, and a lot of the trends are about the same. So it's in 2020, since 2020, and I don't know why, I don't think anybody knows why, there has been an increase in almost 23.3% in the number of donors. Now, the important thing is that these this increase in donors was mainly driven by donation after circulatory death. The number of brain death patients has remained constant around 10 to 15,000 per year. When you look at this graph, these are graphs which have come out of OPTN. They are national data which has been compiled. These are the number of donations. There's almost 25,000 donors per year in 2025. The problem is that there is almost 12,000 organs discarded every year. This is a figure from 2024. And the number one reason that they are discarded is because people have been forced to do super rapid recovery after declaration of circulatory death. When you do super rapid recovery, the kidneys usually can withstand the period of anoxia or hypoxia, but the liver suffers. And as you know, no liver surgeon will be willing to put his patient at risk with an organ that may not function. So the solution for this is, this is just a collage of the number of publications that came out about this organ wastage. Because everything we do in transplant attracts public attention and scrutiny, and there was a lot of negative fallout from this fact in the US. This is in my own OPO, of which I am now the medical director. As you can see, the number of DCD donors has jumped up to 40% in 2023. And there was a small decline in 2024, and that is again on the uptick. So 30 to 40% of all donors are going to be donation after cardiac death. Now, we've had a little discussion about DCD versus DBD. The lower square on that slide shows the number of patients who were primed for DCD donation, but they progressed to brain death. And the whole donation could happen in the usual way as in brain death donors. In 2021, there were 50, and in 2024, there were 41 in my OPO. So that is possible. These are the organs transplanted. The grey line is kidneys. As you can see from DCD, there have always been a majority utilization of the livers. 130 livers in 2023 and 119 in 2024. The red lines, the red bars are of liver recoveries, and as you can see, these have been going up. Not all of these are because of NRP, many of them are because of machine perfusion. And X5, so you recover the liver super rapid, and you put it on a machine which will perfuse it on, until the time of transplantation. So what are the lessons for us from the US experience? Number one, DCD is the main growth area in transplant as of now. Organ wastage is a problem, and I would submit that NRP is the best solution for solving this organ wastage, because you can prove organ function before you explant it from the donor. This is the number one thing. The legal hurdles are several and continue to be a challenge to uniform application of NRP. And till now, there is no consensus on who should actually do the NRP procedure. Should it be a transplant surgeon who has provisionally accepted the liver? Should it be the cardiac surgeons who have provisionally accepted the heart? Or should it be trauma surgeons, because trauma surgeons usually run the surgical ICU? Should it be the organ procurement organization, where you can consolidate a lot of experience? If the OPO surgeon goes out and does the NRP, and if another surgeon wants to come and recover the liver and the kidneys, so be it. So there is no need for us to repeat these kind of fumbling and hesitation approaches in India. Some definitions and clarifications. This is the jargon of DCD, WLST, withdrawal of life support. It is important to know that this is done by the treating doctors, usually the intensivists, and they are allowed to give sedation and comfort measures. The most common ones being in the US presently are morphine, fentanyl, and one benzodiazepine, either Ativan or Versed, at the time you take the endotracheal tube out. The location can be OR versus ICU, and I believe uncontrolled DCD is best transition to super rapid recovery and not try to do NRP, which requires that you go an hour before, set up the OR so that you get a successful outcome. The duration that you are permitted to do withdrawal of life support before you transition to comfort measures only is determined by each hospital. Usually it's about 120 minutes. After 120 minutes, if the patient has not died, you have to take the patient out of the ward and keep them in an area of the hospital where they do comfort measures only. The other question which arises is what is warm ischemia or functional warm ischemia? Should it be systolic blood pressure 80 or should it be 50? We all know that at systolic blood pressure of 80, some circulation is maintained. Mean arterial pressure is definitely very often over 60, and so perfusion of the organs keeps going on. And you don't know, this can last 1 hour, 1.5 hours, up to 2 hours. But usually when systolic blood pressure drops to 50, death is imminent, flatlining is imminent, and within 10 to 30 minutes, death is going to happen. Pulse ox used to be a criterion for monitoring warm ischemia. It is now consensus that this is useless. So now, what is the time that the organs are ischemic? This is the agonal phase, whatever you describe it, from the time BP is 80 or 50, plus the no-touch time, which is 5 minutes, as we have already alluded to. Then the time taken from incision to start of NRP. Only this time is within our control. And there is a consensus that this time should be less than 10 minutes. Most of the time you can do it in less than 6 minutes. And if you start going over 10 minutes, then people say that we don't want to accept these organs. So that is why the surgeons who do it should do it on a regular basis frequently to get this aspect of the surgery correct, and in the hurry to do things, don't, because we all know when you're in a hurry you can make mistakes. So once there is a DCD, you have two decisions to make. Basically, is it going to be a super rapid recovery? Is it going to be a normothermic regional perfusion? We've already touched on this. Should it be cannulation in the chest? Should it be cannulation in the abdomen? And you also have to figure out the warm ischemia acceptable to each organ or center. So one center may want the heart, the patient is highest on the list, but they'll say the functional warm ischemia time is more than 30 minutes, we are not accepting the heart. Another center may say we will take it at 45 minutes or 30 minutes. So you have to figure this out before you do the NRP, and you have to plan the site of cannulation with all the surgeons who want to be there and who want to be involved. Most of these organs which are procured by super rapid are put on a pump, either hypothermic, ex-vivo or normothermic. What are the criteria to help predict circulatory arrest? This is a purely intensivist experience. This is his art, this is his science. I am not in a position to really advise on this, but usually these are the criteria which are looked at. What is the age of the patient? How many pressors is he on? What is the BMI? After that, it's all to do with the airway. Is there a gag reflex? Is there a cough? Does the patient have tracheostomy or endotracheal tube? What is the peak inspiratory pressure of the cuff deflated? Are there any spontaneous breaths? Once you have absence of spontaneous respiration, absence of cough, generally speaking, in an older individual with a higher BMI, you are going to get WLST to cardiac arrest time, which is acceptable to most of the recipient surgeons, or within 30 minutes. This is what we use as a tool. It's a point scoring system. For each of those things that I mentioned, you can give 10 to 30 points. If the patient scores more than 180 points, is more likely to arrest. This is a way of auditing the tool. As you can see in my center, it's only got a predictive accuracy of 71%. Now this is a picture of what we're doing. The one with the back to the camera is me. The one on the other side is a doctor. He's a Sikh gentleman from Northeast, and he came and he was doing a TA Nrp, and I was helping him, and I was there to just procure the abdominal organs. So till the end of last year, we had done 27 facilitated, what the OPO facilitated as runs, and all of the performance of transplant centers and OPO is monitored in the US, and so we had by the end of last year 26 transplants beyond what was expected from the yield of DCD. And so this became a big news and became a big factor in how we go forward with the NRP program and push it forward. This is the beginning part of this year. We've done another 6 cases, and we've had 16 organs transplanted, whereas only 9 organs were expected to be transplanted from those donors. What are the principles? I think we've gone over this in extensive detail during the preliminaries to this, so I won't get into this at all. We've got perfusionists who've explained this whole concept of reservoir very well. What we tend to do is, before we go out to the hospital where this donor is located, we have a pre-flight huddle with all the surgeons who are likely to be there. It is conducted on Zoom. We discuss with the liver team the acceptance criteria, heart and lungs, and who is the surgeon going to perform the NRP, and will it be the same surgeon explanting the organs. In the OR, it is important for an NRP that the surgeons and the NRP perfusionist team arrive at least 1 hour before bringing the patient to the OR. It takes about an hour to set everything up and to alleviate the concerns of the hospital scrub tech and all of them. You have to arrange one Mayo stand, I'll come to that. And you have to position where will the perfusionist be located. If you're doing TA NRP, they have to set up all their equipment and their systems at the head end of the table nearer the left shoulder. If it is abdominal only, you have to set it all up at the foot end of the table. You can't change this once it's all set and the patient comes in. You have to make sure the oxygen source, and I was very happy to see that the perfusion equipment demonstrated in Manipal has an independent cylinder for oxygen. Otherwise, you have to connect with the oxygen source which the anesthetists use. You have to make sure all those connections are okay. You have to have 2 sets of suctions. One suction or two of those suction ports will go into the NRP circuit. They are effectively a cell segment. There will be other suctions which are just trash suctions. They cannot be mixed. You have to discuss who will pronounce that and the process. Leave the OR after prepping and draping, sit in the doctor's lounge or in an adjacent OR, let the family come in and sit with the patient. They sit behind the plate, where, normally where the anesthetist sits. They keep a hand on the patient's pulse, they watch him, the anesthetist withdraws support, and then they sit with the patient until the cardiac circulatory arrest occurs, at which time they leave. Now it is important that you go fast. So you cannot have 30,000 instruments on the table, which normally will be there in the OR, and then ask for, I want this, I want that. So this is how I set up the Mayo stand, which I will use. Now you can see that there is you can identify the sternal saw. That is on the top right corner. On the left side, you will see a Hemlock clip. See, the reason I put this there is that the critical structure that you have to ligate is the left innominate vein. If you don't ligate this properly and it starts bleeding, it bleeds so badly, everything gets slowed down, you can't see any anatomy after that. Very secure way of clamping the left innominate vein. Endo-GIA stapler is used by the cardiac surgeons when they come. It's cost $2,500, one shot. This is, I don't know how many, $5. So use this. If you don't have this, you can use an arterial forceps, an artery clamp. And on the right side, you have to stitch and take it out. On the left side, you can leave the clamp. The less hardware you have in that middle of the sternotomy, the better. There is the sternotomy retractor I have not shown here, but you can see at the bottom, okay, near those 4x4 gauze pieces, there are 2 bovie pads. Those are scratch pads of the bovie. The black part is the part you scratch the bovie on. On the other side is a sticky surface. So when you use the sternal retractor, before you prepare stick the bovie pad onto the blades of the sternal retractor. Because then when you put the sternal retractor into the sternotomy and you start cranking it, it opens, it doesn't slip. See, the only way to get speed is every step you do is done once. You should not have to do a step twice. If you put a lap pad to help it secure, that lap pad comes in the way of your crank. You don't want any, Ravi was saying you can put a towel clip. Yes, but then that's more hardware sticking in the way. This is a simple solution. That Sardarji, who was studying with me, he taught me this trick. It works perfectly. Indian Jugaad works perfectly. Okay. The others are usual instruments. There is, time to solve. This is the table which has to be kept warm. This is the handover. The person's hand is the one with the NRP technician. The other one with the gloves is taking the tubing. This is the surgical steps. We've already talked about it. The perfusionist has to confirm good venous flow. This is critical to the conduct. It's usually possible under 10 minutes. I've talked about ANRP and TANRP. I don't think we need to. This is the picture of TANRP with the perfusionist on the left side at the head end. the tubes are coming and going out of the sternotomy, the abdomen has been opened, but it's covered with a clinching. This is when Nrp, the perfusionist at the foot end of the bed, and this is the charting they use every 5 minutes with ABGs done every 5 minutes. And this is a case which was kind of strange for me. The patient was already on ECMO, was brought into the OR with the ECMO on flow. Cannulation was done in the femoral artery and vein. And this is the patient. The ECMO machine is the one closer to us, and the Nrp is being set up further away from us. Once the patient withdrawal of life support, the Nrp was stopped, clamps were applied, and the patient was allowed to pass. And once the patient died, we connected the tube to the Nrp machine and got going. So in summary, we have to start thinking and planning for DCD, and I congratulate Dr. Avnish for really pushing the envelope, moving us forward. SR super rapid and Nrp are the two options. Choice depends on which or how many organs are transplantable. Surgical approach is similar. Nrp is best done in a planned manner, setting up the OR, which usually takes, in my experience, half an hour to 1 hour before you can start. In an uncontrolled potential DCD situation, where there is the option to start ECMO in the ICU, well then that's great. Okay? With those, I thank you all for patient listening and best of luck.
Because I think it's the whole standard today. In my hospital, because they predict the ones who will die on time. And that is the most important. In Spain, it's only the cases who go to the ones that in the clinical session in the morning, the intensivists predict this guy will die on time. And second, is who support the wound road. It's not the last doctor, it's not the youngest. It's the team of anesthesiologists who monitor the disease, the blood pressure, the transesophageal blood, and give sedation, give anesthesia is allowed in our country. And that means that in Spain, 100% of the potentials die in 17 minutes in average. That's allowed to use the organs. And another issue that I know that Anil Kumar you can have in your presentation is possible. The big difference between probably Spain and our countries. We are allowed to put heparin before the procedure. In other countries is not. And second, we can pre-cannulate before the wound out. So that gives a big advantage. Like the last case that you mentioned that the body came already with the ECMO placed, which that is what we do. But I don't like to talk more because my friend Eduardo Viñan will speak the Spanish experience, but I think you're a model, how you transfer your experience from Nrp to Texas and make it possible. But let me insist again, the same from the DVD, how you know from me, that intensivists is the key point. That once we will identify or predict DCD are intensivists, should be in this program. So one part is intensivist, second part is anesthesiologist supporting the wound route. Third part is the perfusionist, he will tell me the pH, the lactate, what is the situation. And the surgery will be a normal surgery, like a heart-beating body, because the body is already on the Nrp or thoraco-abdominal Nrp. And you need in this way, because this morning you visit the ICU, with the chairman of critical care, you have the department of anesthesia, and also the perfusionist. I think it's a good issue that we did this morning. These are the three elements. Surgery comes after. Thank you for the opportunity.
There's a question online. So, what is the difference between Nrp and eCPR?
And
eCPR.
But while compressions of the chest are going on, they put in the cannulas in the femoral artery and the vein and get ready to start ECMO. And I think, our intensivists and all may be more familiar with that. I've never done ECMO CPR. I've only seen the benefits of it.
So, intention of eCPR is to revive the patient?
No. ECPR is basically a bridge to decision. This is in those countries where there is presumed consent for donation.
Like Spain?
In France, Spain. So there they have a very strong, robust eCPR program. So almost most of the patients are put on eCPR and a decision is taken whether to continue on the eCPR or it goes on to donation.
So no, I would beg to differ, sir, because one of my residents.
Bridge to decision.
Bridge to decision, sorry, I got bridge to decision. Yeah, decision.
So, should we close this session?
Just like a small comment, ECMO is CPR in Spain. Patients who have a cardiac arrest outside of the hospital with a refractory treatment, they came from ECMO CPR. What are the results for these 100 cases? Patient will survive, but
no, I think just in a controlled environment, the potential for for a negative outcome is also quite high. So not because the chances of not progressing on to death are quite significant in the controlled DCD setting. So just to be introducing three things: controlled DCD, controlled DCD, withdrawal of treatment, as well as NRP. And all these three things have rarely been introduced at the same time in a population anywhere in the world. It's always been stepwise elsewhere.
Thank you. I will close the session. Thank you.
and being pioneers in DCD and use of NRP. So, looking forward to the discussion.
Thank you, Amish, and good afternoon to all of you, and good morning to my friends from Europe. Great pleasure to introduce Professor Chris Watson, who has been trained there for liver, kidney, and pancreas transplant. He has a great interest in increasing the organ donors and making the most of what is available. One aspect is to quantify the risk of donor-transmitted disease, in which he has interest. In 2010, he started the first NRP program for controlled DCD donors in the UK and has worked on national NHS team to apply for common funding to reduce NRP across the UK. His other current interest is monotonic liver perfusion, and he oversees the NMP liver program in Cambridge, which he began in 2014 and has performed over 500 perfusions. So, great pleasure to have you, Professor Chris Watson, and we would like to hear the experience from the UK of DC donations. I know that UK donations have increased. Number of donations have increased by 33% using DCD donors. So, over to you, Professor Chris Watson.
Thank you very much for inviting me. I'm honored to be here, and congratulations on this initiative. For my presentation.
A little feeble on the voice. Can you just get closer to your mic, please?
Okay, let's say that's better. I have a declaration of interest. I'm a consultant to organ option. That's my talk. So the problem with DCD livers in the UK when we started was that if you had a DCD liver, you were twice as likely to die within 3 years and twice as likely to lose that liver within 3 years through primary non-function or poor function or angiopathy. And that was the setting that we faced when we tried to do something about it. In the UK, when treatment is withdrawn, the clinicians intensively stop iron throat for most partners for the patients. And it usually takes place in the theatre complex. It may take place in the intensive care unit. We're not allowed to do comfort measures. Death's verified after 5 minutes, and it's the absence of the blood pressure, as we've heard previously from, overturned my perception of DCD donation. They restarted the heart in a DCD donor, proving that it was possible, but also, as you've seen in the video, that the liver looks fabulous and the kidneys look beautifully perfused. And it changed our perception of what we should be doing with DCD donation. And you can see even when we had peristalsis in the small intestine. So we spent 4 years negotiating ethical hurdles. It took us before we realised the short-term outcomes were so much better. And in 2019, in collaboration with colleagues in Edinburgh, we published a paper that showed actually we had no angiopathy in any of the patients that we've done to date. And that coincided with a publication from the Spanish group from Amelia Hesheimer and colleagues, showing that in Spain they'd also got an NRP program and were seeing no angiopathy.
When we started, we were using whatever equipment we had around. So this is an old Medtronics pump, and we used trained cardiac perfusionists from Papworth. We've progressed to using some commercial equipment, initially the ECOPs, then the donor assist made by Organ Assist. They no longer are available. And we moved to the Nrp cardiac health. But these are fancy bits of equipment that you don't necessarily need to use. We started by cannulating the aortic arch and left atrial appendage. I'm not a cardiac surgeon, so that didn't go too well. We moved to cannulating the right pulmonary artery and IVC, trying to get the venous cannula tip in the right atrium. And then we faced with a patient with ankylosing spondylitis who we couldn't lie flat on the operating table and we couldn't access the abdomen quickly. And we decided at that point that we needed an alternative route. At that point we started to cannulate femoral vessels. Artery first and then vein, because if you cannulate the vein first and get spillage, it's very difficult to identify the artery. So we now preferentially do femoral cannulation. If the donor is very obese, then the abdomen may be better, but generally femoral cannulation. We used to use the larger cardiac cannulas, but now we use the ECMO cannulas for the femoral cannulation. There are one or two anatomical anomalies that have complicated things. We've had a horseshoe kidney, but that was perfused very well. We've not seen a pelvic kidney, but we have had a type 2 retroaortic left renal vein, as you see in B in the diagram below, where the femoral cannula finished up in this left renal vein, and we spotted that when we opened the abdomen. When we do femoral cannulation, our next move is to open the chest, put a cross clamp across the thoracic aorta, and at some stage later we'll look in the abdomen. We don't necessarily need to do that straight away. In the UK, there are serious ethical concerns, and in particular the guidelines to certify death insist that we do not restore blood flow to the brain. And to ensure that we aren't restoring blood flow to the brain, we place a 24-gauge cannula into the ascending aorta and just leave it open to air, as you can see here. And this is on full ECMO, and you can see there's a column of blood in the cannula of about 3 centimetres. So that's 3 centimetres of pressure. That's not sufficient to perfuse the brain, and we're reassured then that there's no cerebral perfusion with our clamp on. You can just see in the chest there a clamp on the descending thoracic aorta. We prime the circuit initially with Hartmann's compound sodium lactate. That gives us a lactate bolus from which we can subsequently see lactate 4. And then subsequent to that, any volume replacement is either with gel infusing or with blood. We give 50,000 units of heparin into the prime. We're not allowed to give heparin before donation, so 50,000 into the prime. We give 1 ml of 8.4% bicarbonate per kilogram of donor weight. We add some antimicrobials. We give methylprednisolone because we give up the DVDs, it seemed a good idea. We give phentolamine to counter the alpha vasoconstriction that you get during that withdrawal process. You get a lot of catecholamines released during the withdrawal process, and phentolamine helps to counteract that. And then we give blood as required. If there's a chest team taking the heart or the lungs, there tends to be a lot more bleeding and therefore a lot more blood required. But typically we end up giving about 2 units of fat red cells during the 2-hour perfusion. We don't have trained cardiac perfusionists anymore. We use trained theatre technicians to run the pump. They do blood gases every 30 minutes. Every 60 minutes we do a function test with this near-patient device called a PICO-L from Praxis. And that will give us a transaminase reading. And we do blood counts at the beginning and end just to make sure if there are any microorganisms present, we can identify them early and also the recipients. For viability, we look at the ALT at 2 hours. If it's less than 200, we're happy to use the liver. If it's more than 500 and less than 1,000, then we reassess the liver on our organ oxygenation device. The results of livers that we've had to reassess aren't that great. So actually we think our criteria of an ALT of less than 500 are actually quite good. The lactate we'd like to see falling. It doesn't always fall far, but it should fall. And the glucose we'd expect to rise at the beginning of the perfusion and then fall. And this is a response to both warm ischemia and the adrenaline release during the withdrawal phase. If the glucose doesn't rise, it's an ominous sign. So they run the circuit for 2 hours unless there's catastrophic loss of volume. The aim for flows of around 3 litres a minute in an average adult, and we're confusing the abdominal organs and the contralateral leg. And we manage the whole thing looking at the venous oxygen saturation. And the cardio pump has an inline monitor for venous oxygen sat, so we can monitor that. And we aim to get sufficient oxygenation to get a 60 to 80% of venous oxygen saturation. If the sats go low, then we can either give more red cells or we can wind up the pump speed or do both. We can adjust the pH by adjusting the gas flow across the oxygenator. And the gas flow is typically an oxygen air mix, it's not pure oxygen. We just aim to get 100% saturation of the arterial blood. So in the Cambridge series, we've done 351 retrievals to date. 2 of the 61 have resulted in liver transplants, that's 75% utilization. We use these livers in any sort of recipient, so 9% of these have gone into retransplants, 6 have gone into our highest urgency patients. So the melded recipients have been just over 17, but our range of melded recipients is up to 43. So we would put these livers into anyone, they're very robust livers. And just to give you a demonstration of that, this is the UK DCD donor risk score. So this is a score that was drawn up, initially based in Birmingham and validated on UK data, looking at the outcome of DCD donor livers in recipients, and based on donor and recipient factors, scoring points for each of those, you can see that the best prognosis group, if there were more than 5 points, had a survival of just over 80% at 5 years. The high-risk group, the 6 to 10 points, had a survival of under 60% at 5 years. And if the score was over 10 points, they were classified as futile with a survival of less than 20% at 5 years. If you do NLP, and these are our data for NLP, you can see that every risk group, from low risk to high risk to even futile, has got an outcome at 5 years of around 80% or higher. So NLP completely transforms your DCD liver transplant program. Not only are you using more livers, but they're working just as well as DBD does. In terms of early allograft function, Barreja and colleagues from Spain produced a score called the Monster Early Allograft Function Score, where 0 is bad and where 0 is good and 10 is bad. And we have a score of 4.2, which is very good. And under the Althoff criteria, only 12% of our patients get early allograft dysfunction following NRP DCD liver transplant. We know that DCD liver transplant is associated with acute kidney injury. From a study by Lithed and colleagues, 53% of DCDs with rapid retrieval suffer acute kidney injury, and 31% of DVDs. And with NRP, we see 33%. So just similar data to DVD livers are much better than DCD livers. So the moment you get better early function with less early problems, you get better long-term function. In terms of biliary outcome data, we have a leak rate of around 5% and an anastomotic rate of around 12%. But in terms of non-anastomotic strictures, which is a real disabling thing, if you exclude our PSC patients, it's 3% at 12 months. The PSC patients have a much higher incidence, and indeed at 12 months it's 15%. And I think that probably represents, rather than ischemic angiopathy, the recurrence of that PSC. None of our patients who've had NRP, DCD livers have gone on to require retransplantation for angiopathy. What about donors that take a long time to die? So traditionally we use donors that die very quickly because we were trying to predict the way that these livers work. And we've become very relaxed about this. So our median withdrawal to arrest time is 14 minutes, but that ranges up to 227 minutes. So we're quite happy to wait for the donors to die. The systolic time of time with no blood pressure, our median is 17 minutes, but the range is up to 32 minutes. And 32-minute liver recipients did very well. And our functional warm ischemic time, so when the systolic pressure dropped to less than 50, reperfusion on NRP is a median of 37 minutes and a range of 72 minutes. And we try and tell our trainees who do this to take their time, because NRP allows you to take time doing retrieval. You don't need to rush so much because you're restoring the circulation and replenishing ATP on NRP, and the livers and kidneys do much better. In terms of cold ischemia, our median cold ischemia time for these livers is around 7 hours, but that's ranged up to 13 hours with very good results. And just to show you that, in terms of withdrawal times, whether it's more than 60 minutes or less than 30 minutes or between, you can see there's no difference in transplant survival. The transplant survival is graft survival without censoring for death, so if the patient dies, it counts as a failure. And the same here for functional ischemia, whether it's more or less than 30 minutes, there's absolutely no difference in outcome at 5 years. The UK expansion has been slow, largely because we don't have national funding yet, and it's been funded largely by charity and local hospitals. But 7 out of 10 of our national retrieval teams now undertake NRP. We have a national protocol, a standard operating procedure, a competence document that they have to meet before they can go on and do NRP. And we've got a passport that has to accompany the organs to the liver and the kidneys when these get distributed. We have a debrief after each case for new centres starting, so we can make sure they're doing things right and pointing in the right direction. And for every centre doing NRP, we have a national debrief by teams every month to present cases for interest and for learning. So just to summarise, NRP is, it is easy to learn and to perform, and as time's gone on, we've realised there's no need to rush retrieval. Liver and kidney utilisation are much better than with rapid retrieval. Not only is utilisation better, but outcomes are superior. So liver, I've told you, but even the kidney outcomes are better with a typical median GFR of around 6 mils a minute better at 1 year. And chronogeography does occur, but it's very uncommon and it's seldom limited. Thank you.
Thank you for sharing your experience from the UK.
That was a very great lecture and experience, because it's considerable in terms of time. And one of the most interesting things that Professor Watson just said is biliopathy may occur, but it is usually mild and seldom limiting. So just having a diagnosis doesn't mean the liver is trashed, and that is very encouraging.
So do you have less discards compared to what you guys have in the US, from what I can see? The UK has better utilization this time. Am I right? I'm not a
I don't have the national data, so I'm still limited to what's called Region 4, and I would say that we're perhaps performing as well as the UK, probably.
But the functional warm ischemia was slightly longer than what you said.
Yes, your functional warm ischemia is, I think you said it should be 6 minutes ideally, it should be 6 minutes.
No. That is incision to perfusion.
Start of it.
But the functional warm ischemia time is where the blood pressure drops below 80 or 50. You have to decide which is going to be your cutoff. Professor Watson is describing functional warm ischemia from systolic blood pressure of 50 onwards. So maybe we should adopt 50.
Brian, you want to say anything?
To be quite honest, we now ignore the term functional warm ischemia because it's no longer relevant. We used to use it when we were trying to predict whether the liver would work, but now you can test the liver on the machine, and we've got away from being dictated by the timings. We just want to see how the liver's working, and that makes all the difference to us.
Chris, thank you for bringing up that very first case, which was also my baptism of fire. And then told me that it was going to work, and I recall within 4 minutes we had spontaneous sinus rhythm, and you were so excited about the urine being produced. But you had quite an experience from then on with TA-NRP, and I know there's a moratorium in the UK, but if it weren't for that moratorium, could you suggest what the peri and survivorship data would look like with the TA-NRP cohort compared with your abdominal NRP?
So initially we had we had another issue with TNRP with getting protocols sorted out, but the outcomes of the organs, the liver and kidneys were very good. The main reason for the moratorium, as you may have said, is the concern about the fusion of the brain. And I think the evidence now is that if you're draining the cerebral vessels, so if you drain them to air, there's no perfusion pressure. There can't be a perfusion pressure if you've opened all the cerebral vessels. And therefore it's probably safe. And we're very keen to see that restart because it makes a huge difference to the cardiac function and restore the circulation in situ rather than have to put it on another machine. And the kidneys and liver work very well that way. And there's also less bleeding in the circulation if the heart's left in place rather than have to remove it with the attendant bleeding that happens.
Last comments from Brian and then we'll close.
Yeah, I want to congratulate Professor Chris Watson for his presentation and for the great results we're having in Cambridge. And to highlight two things that you mentioned that I think are very important. In the discussion, one of them is who is performing the NRP in your setting, skills and training in managing this NRP and the whole procedure. And the second thing is this dilemma or this fear of guaranteeing that there's no brain perfusion. I agree with you that now it's very clear that in abdominal NRP there's absolutely no discussion that there is no chance of having brain perfusion if we guarantee there is no flow to the thorax, right? As you did when you clamp your abdominal aorta or either when you use poverty balloon to avoid this flow, then we are safe that there will be no issue. But the big discussion is on thorax abdominal NRP. And as you mentioned, now if we can cut and drain the vessels to the brain, then we are safe. But there are many teams now doing research to try to demonstrate that this is safe. But I think that as a message is that don't be afraid of abdominal NRP because there will be no ethical risk on doing this NRP because there is no chance we're going to restore circulation to the brain. If we take these measures that you did, for example, having this camera in the thorax, to guarantee there is no leak in the system or using an arterial line to guarantee them, to monitor somehow that there is no leak in the system. But if there is no leak, it is a safe procedure.
Thank you, Brian. Naraj, you want to say something? Professor Chris, can you answer the question on the chat window from the 37 or 50 odd people online, I think, or little more. So can you answer the question if you don't mind on the chat window? And Naraj, you want to say something?
Chris, do you want to go first? The question is also our experience with organ function prior to NRP, and it wasn't good, and that's why we went to NRP. We had a long-standing program of DCD kidney transplantation, and we're very hesitant. But when NRP came along, it's completely transformed our practice, and the majority of our transplants now are NRP liver transplants. And in the UK, DCD donation is now overtaking DVD donation as the commonest form of deceased donor transplantation or donation.
Slightly stretched for time, so Rayas, please go ahead.
Just a very quick thing. So, Chris, the UK has 7 liver centres and 10 retrieval teams. Most Indian cities have that existing in one city itself. Tell us about the difficulties in terms of widening the practice of NRP across these 7 centers and 10 retrieval teams, because I think that's an important message that does need to get across. And 2 is, how would you advise, India a fair bit, in terms of what one should do to move the theory into practice in an Indian setting? So the model that we've adopted, we have a national training days so people can come and train with us. Then we send a perfusionist and a surgeon out to the centre that's learning when they have a DCD donor so that they can assist them going on to NRP. So it's a system of mentorship where someone will go out to the centre, a kind of flying squad if you like. So colleagues of mine, colleagues in Edinburgh who also do this, will go to local hospitals. Yeah, we've been to Birmingham and down to King's and for their retrievals, and Edinburgh been down to Newcastle, and that's how it's worked, and it works very well that way.
Thank you. I think we should move forward, and thank you everybody for listening to Professor Watson. We now go on to the Spain experience. So over to you.
Thank you. Thank you, Dr. Lee. So I will now request Global to take the chair along with Darius, and Darius, of course,
having been at it for many, many years, is currently a professor at the University of Cantabria. He is also currently at the moment Marqués de Valdevilla in Santander, Spain, and head of the transplant coordination unit. And with a particular focus of his academic and clinical practice in improving therapies and protocols to reduce post-mortem functional damage to solid organs, the use of ECMO to improve ischemic damage and DCD donation, and finally, more recently, the use of ECMO to combine thoracoabdominal solid organ retrieval in the DCD setting. So over to you, Professor Menambris, and we'll have some questions for you afterwards.
So you are on mute.
Sir, we can't able to hear you.
Eduardo, you're muted.
Can you hear me now?
Yes.
Okay. Thanks. First of all, I'm so proud to be part of this meeting. Thank you very much to the organizer for inviting me. And I'm going to get you some data of how the Spanish model is regarding the DCD donation. We started with our controlled DCD program and uncontrolled DCD program in 2012, and from the very beginning, we decided that the Nrp is the ideal method for organ retrieval. We have never performed a DCD donation with the super rapid technique, and we performed in our center the first Spanish pancreas transplant from DCD and the first combined liver and kidney transplant from DCD. In 2020, we did other two centers in Spain the first case of heart transplant obtained from controlled DCD donors using thoracoabdominal Nrp, and we were also able to set up our pediatric DCD programs. In 2021, we obtained a heart from a neonatal donor in 3 days using post-mortem thoracoabdominal Nrp. These are data from Spain. As you see, in the last decade, we have increased so much our donation rate because of the controlled DCD donation. And these are data of my region. In the last years, we have, for 10 consecutive years, my region has achieved the first position in Spain regarding the ratio of DCD donation and DVD donation. Last year, we had 94 donors per million population. And as you see in this slide from the international registry, these are data of the annual rate of DCD donation rate from DCD donors. Spain achieved 22 DCD donors per million population, and in my region, we nearly achieved 60 DCD donors per million population in 2024. That's, in my personal point of view, the key points of the Spanish model. We don't consider that we have to engage the densities. We do think that the ICU physicians must be the leaders of the transplant coordination units. The Nrp procedure is always led by the transplant coordinator, and as Marty said before, in Spain, pre-mortem interventions are allowed. We can use heparin and we can perform pre-mortem cannulation of the potential donor. And I do think that it's so important that before starting our controlled DCD programs, it's mandatory to have some protocols of the care of the patient and the end of the lives. So palliative care and comfort care measures are part of the treatment in all patients, no matter if they are going to be donors or not. But that's very important to have this type of protocols before settling
are DCD programs. As I said to you, from the very beginning, we did consider that the results of the with Nrp would be much better than the rapid recovery technique. So I don't have experience about the rapid recovery technique. These are the three initial experiences published by PubMed using Nrp in controlled DCD donors, the experience of Michigan, the UK, and our own experience in Santander. From the very beginning, even with the very early learning curve, we demonstrated that the rate of coagulopathy, this chemical coagulopathy from the liver, was much lower than the observed in rapid recovery technique. Some studies, as this very well-known study from Professor Watson, demonstrated that the results in liver transplantation with Nrp was much better than with rapid recovery technique. And finally, the studies from Spain with nearly 800 liver transplants obtained from controlled DCD donors demonstrated that the graft loss, the biliary complication, and the ischemic coagulopathy decreased so much with Nrp. So that's the ideal technique for DCD donation. The same for the kidneys. The results are much better with Nrp than with rapid recovery technique. And this is how the method is in Spain. As I told you, we are allowed to perform pre-mortem calculation. So once the withdrawal isothermal therapies have been performed, we wait until cardiac arrest. The non-touch period in Spain is 5 minutes, and in that precise moment, death is declared. So we fill the thoracic aortic balloon, and the abdominal cavity is well preserved. As you see, we maintain the Nrp for at least 2 hours, checking the lactatum values, the liver enzymes, we use fluids, and of course, our goal is around 2.84 liters per minute. That's quite easy. In Spain, we have avoid the rapid recovery technique in blue, and we have increased so much in yellow the percentage of procedures performed with abdominal Nrp in yellow, and also abdominal Nrp in blue. That since 2020, when we started our heart transplant programs, we have increased so much in the last 5 years, as you see. So today in Spain, only 10% of the procedures, only focus in kidneys, are still recovered with the rapid recovery technique. And my personal impression is that it's a wrong decision. I mean, Nrp is much better for the kidneys, and in Spain we have very good experience with that. We have portable devices, we have ECMO mobile teams for getting the Nrp in all centers across the country. Well, the next step was to combine the abdominal Nrp with the lungs, and the people from the UK were the first one to describe this technique. And later, in my center, we were the first one who had great numbers of lungs obtained from controlled DCD donors using Nrp. Our approach is a bit different from the UK approach. This experience, published in 2022, is the largest single center experience published in the literature up to now, and we compare our 60 lung recipients, which lungs obtained with simultaneous use of Nrp for the abdominal grafts, with controls, DVD donors. The results were identical. We achieved very good results in the short, mid, and long term, with identical 5-year survival than those obtained from lungs from DVDs. And I would like to emphasize that the age of the donors were identical in both groups. And this is the Spanish experience, with more than 200 lung transplants obtained simultaneously with abdominal Nrp versus nearly 2,000 lungs obtained from PVD donors. And the most important thing is not only the liver and lung recipient survivals, also is important the organ utilization. The organ utilization for livers and lungs is identical to the organ utilization of liver and lungs obtained from DVD donors. We have developed so well these procedures that the organ utilization rate for liver and lungs is identical than DVDs. And this is how our protocol is. Once cardiac death has been observed after 5 minutes of no-touch period, we always preserve the abdominal cavity. And later on, it's up to the surgeon to perform a sternotomy. We restart the mechanical ventilation to the potential donor, and we cannulate the pulmonary artery as soon as possible. That's the moment in which our thoracic surgeons perfuse the perfect solution throughout the pulmonary artery, and that's the moment in which the lungs are pretty well preserved. That's the moment in which our abdominal surgeons start with the laparotomy, and we have two different types of temperature: normothermia for the abdominal cavity and slight hypothermia for the lungs. After 20 minutes, the thoracic surgeons perform his measures, some kind of quick maneuvers or similar, and later on he's up to recover the heart and the lungs as a block. They take this block and we maintain the abdominal cavity with Nrp for an extra 60 minutes. The cava vein clamp is the more critical point because we decrease the perfusion, we can lose the flow of the thorax and the heart. And as you see, we have increased so much the number of lungs obtained from DCD donors in Spain. And our most challenging approach, our most challenging step was to introduce the thoracoabdominal Nrp obtained for recovering the hearts. We have learned a lot from the people of Padua in Cambridge. We have adapted the protocol to our hearts, and as they published in 2020, the results are quite promising. In 2021, we published our first experience with hearts obtained from controlled DCD donors using thoracoabdominal Nrp, and I would like to emphasize that we never use ex situ devices. We always preserve the hearts in cold storage, and we achieve at the initial cases very good results. In 4 years, we have increased up to 211 hearts obtained from controlled DCD donors in Spain, and we have obtained hearts from 25 different centers. So we have been able to obtain hearts not only in the big university centers, but also in so many centers around the country. And this is how the procedure is. We always cannulate the donor, as I have told you before, and we always preserve first the abdominal cavity. Once cardiac arrest has been observed, and after 5 minutes of non-touch period, death is declared. We fill the thoracic aortic balloon and we preserve the abdominal cavity. Later, it's up to the cardiothoracic surgeon to perform a hysterectomy, to connect to mechanical ventilation, to clamp the supraaortic vessels. And I like to emphasize that clamping the supraaortic vessels is not enough. We have to section the distal ends, and later we extend the abdominal Nrp to thoracoabdominal Nrp with 4.5 or 5 liters per minute. And from the very beginning, in just seconds, the heart starts beating. We evaluate the heart function with echo, esophageal echo, and we decrease the pulmonary flow. And our goal is in 15 minutes, 16 minutes to stop the thoracoabdominal Nrp and maintain this donor with the heart beating, perfusing the other grafts, liver, kidneys, lungs, pancreas, and it's more or less very similar to a DVT donor. These results have been published 3 weeks ago. This is the Spanish experience published in February of this year in American Journal of Transplantation. We published our initial cases, 98 heart transplants obtained from DCD donors using thoracoabdominal Nrp without ex situ devices, always with cold storage, and the results at 1 year, the resident survival were identical to the hearts obtained from DVT donors. And these numbers are quite impressive. I mean, we are comparing more than 300 hearts from DVT donors with nearly 100 hearts from DCD donors. And at the same time, we have been also able to obtain lungs from donors using thoracoabdominal Nrp. I would like to finish my lecture with the ethical concerns about Nrp. Our previous chairman talked us about the possibility to perfuse the brain after death has been declared. I would like to emphasize that as how my colleague said, in Belgium and the UK, they had to stop the thoracotomy Nrp process because of the possibility to restore brain circulation. Spain changed the protocols in 2023. To perfuse the brain with the clamping of the thoracic aortic vessel is not a possibility. It's for sure. We know that throughout the thoracic, the peripheral or the collateral circulation, the brain can be perfused and is perfused. So it's mandatory not only to clamp the supraortic vessels, we have to bend the distal cephalic ends to the atmosphere. That's mandatory. There are some studies, such as this elegant study for the group of New York, in which they demonstrated that with Doppler transcranial ecography, there is no blood flow 30 minutes after the initial thoracotomy Nrp procedure. From my perspective, this is not enough, because they started the Doppler ecography 30 minutes after starting the thoracotomy Nrp. And there were 2 cases in which they had severe brain damage. So the possibility to evolve brain death in these 30 minutes is too high. We must monitor the brain circulation just immediately after the thoracotomy Nrp is started. And this is the only possibility to do that, in my personal point of view. This is our experience using, as I am going to show you, some kind of sensor catheter in the circular wheels. In 10 cases, before the withdrawal isofenic therapy, we place a pressure catheter in the circular wheels throughout the carotid artery. It was performed by our neuroradiologist, and we evaluated the pressure during the whole procedure. This is an example. Once withdrawal isofenic therapy, once the withdrawal isofenic therapy was performed, we observed a decrease in the brain pressure, in the thoracic pressure, and in the abdominal pressure. After the non-touch period, we started with the abdominal Nrp, and you can see how the abdominal pressure is increased. Later, we succumbed to the supraortic vessel, we sectioned them, and once the heart started to beat, we observed an increase in the thoracic pressure. But on the contrary, the brain pressure was maintained at the same level that it was observed during the 5 minutes of the non-touch period. The most important thing is that once the heart was pumping, we had pulsating pressure in the thoracic and in the abdominal pressure, but never it was observed in the brain pressure. I have to insist that there were very few cases, but this is very strong evidence that if we clamp the supraortic vessels and we section them, there is no possibility to restore the brain perfusion. We have been received a budget for the Spanish government. We have increased our study, and we not only evaluate the circulation of the brain pressure in the circular wheels, but also in the basilar artery. So we evaluate the anterior, the middle, and the posterior brain circulation. Up to now, we have included 29 cases, 7 of them with thoracotomy Nrp and 22 with abdominal Nrp. I do think that at the end of the year, we are going to publish the whole experience. And just for this, there are differences about the possibility to restore brain circulation. The people from the US, as you see, they published the residence protocol of using thoracotomy Nrp, and they describe 4 possibilities to guarantee that there is no brain perfusion once the thoracotomy Nrp is functioning. We disagree, and we have published a letter of the editor considering that the possibility C and the option D is not enough, because these 2 options that they are considered by our colleagues from the US, we do think that there is a possibility to restore brain circulation throughout the collateral thoracic arteries. Well, my 2 last slides, these are the number of liver and kidneys transplanted from controlled DCD doors in Spain. As you see, we have increased so much our figures. We have increased so much our figures in livers, and the same results in the lungs, in green, and in hearts. I do think that there is much room for improvement in obtaining grafts from DCD donors using the Nrp devices. And we can also use the Nrp for a controlled DCD donation. I'm not going to spend time in this procedure because it's quite different. I'm talking about patients who suffer a cardiac arrest outside of the hospital. We have just published our results for kidneys. This paper has been accepted in Transplantation Direct and is going to be released in PubMed in just 2 weeks. When we obtain a very good survival rate for kidneys, 92% at 5 years, and we have also experience in lungs. And for summary, I do think that organ donation is the right of the patient at the end of his life. I do think that the health system and his professional must try to preserve this right. Nrp is the best method for organ preservation in DCD donors. And I do think that it's more cheaper than the use of ex situ devices. And then the assessment of the graft before recovery, I do consider, I really know that the legal concerns about Nrp are easily solved with the adequate professionals. And I think that the impact of this donation is amazing in the number of grafts. Reducing the patients in the waiting list, and it has a very good, excellent response outcome. But my last suggestion is that the ICU doctors must have an important role in this donation. And thank you very much for your attention.
Thank you very much. Dead is dead. Why are you worried about cerebral perfusion at all? Because whatever you do to the cerebral perfusion, you are essentially just allowing is declared dead is dead. Let's just forget about, which is what I say, any kind of clamping of anything. Just perfuse the body. It's a dead body, right? And so, but these are challenges that we still have to address, and that's why we have an issue in the United States. There are only 4 or 5 centers doing thoracoabdominal work. I just wanted to ask you just quickly 2 things. One is, if you had the choice of TA-NRP over just ANRP in general, what would you choose now in respect of, again, the same question that I asked Chris, in terms of outcomes, liver, morbidity, and so on, and kidneys too. You're certainly getting better retrieval than anybody else in the world at the moment in respect of the lungs with your protocol. And the second was, what prognostic tool are you using in intensive care to prognosticate the likelihood of progression to circulatory arrest?
Well, the first questions, our results with abdominal graft using thoracoabdominal Nrp have been pretty good. I mean, the results are quite impressive. If I would recover only abdominal grafts, my donor is only available for liver and kidneys, I think the abdominal Nrp, my personal impression, is easier than the thoracoabdominal Nrp. Up to now, I have done in my own center 70 procedures of thoracoabdominal Nrp. Around 300 with abdominal Nrp. So I have more experience with abdominal Nrp. I feel more comfortable with this procedure. I think it's easier to go further with abdominal Nrp than with thoracoabdominal Nrp. So my personal point of view is that if I'm going to recover only abdominal grafts, I do prefer abdominal Nrp. The combine of large retrieval with rapid recovery technique plus abdominal Nrp is very easy. I don't see any kind of complication. But we are still having some kind of problems with thoracoabdominal Nrp because we are not sure that the heart is going to be good enough to pump by itself. So I think thoracoabdominal Nrp is excellent if the heart is going to be recovered standard. But if not, I wouldn't use thoracoabdominal Nrp for all abdominal grafts. That's my personal point of view. Secondly, about the intensities. In a short period of time. There are no this type of methodology. It's the personal impression of the intensivists who can think that it's going to happen or not, because all the tests that have been described are not very useful. But I have to emphasize that we must think about to have the palliative care of the patients and the use of drugs, sedative drugs, analgesics as part of end-of-life care. And that's very important. We don't consider in Spain or in France that once you have decided that the treatment is futile, that the best approach we can give to this patient is to comfort care, we are not going to withdraw the isotonic therapy without any kind of analgesic drug or sedative drug. Is not fair. This type of drug, this type of treatment is part of the end of the life care of the patient. No matter if they are going to be donors or not. We use the same drugs for those patients. We are not able to become donors, but we are using this type of care in the intensive care units. I think that that's the most important thing. Of course, in those cases in which the period of time is so long, we have the Nrp to recover the ischemic damage observed during this long period.
Thank you so much, and congratulations for achieving the dizzy heights of over 90 donations per million population and a DCD conversion of over 50, which is just incredible. Any questions from our international guests? Anybody here have any questions? So, Professor Menendez, thank you so much. We'll continue on from here. Thank you.
Thank you, Prabhat. That was really fantastic. So we now go on to the next session. We will cut it down to about 30. Whatever has been already covered, we will just skip. That was the one. Yeah. So we have been talking about brain death for the last 20 years, and as we spoke earlier, we need to get on with the circulatory death part. And this is a study we published in 2009 that if there is a devastating brain injury, we see brain death 30% and about 70% people die with circulatory death. And I think now our focus needs to shift from those 30% to this bigger 70%. And if we see overall also deaths in the world, brain deaths account for only 2%, 98% are circulatory deaths. So time to shift the focus, already covered. Does the law allow DCD in India? A lot of people have asked us this question, and we have people joining this meeting from various parts. So just to cover the basics, yes. So the answer is yes, because in our 1994 law itself is said that organ donation can be done in brainstem death or in a cardiopulmonary sense. Which form to use for consent? Do we have to create anything special? Again, maybe more by accident than design. We, in our form 8, again, it was there that we could do either in a declared brainstem death, oblique death. So we have the legal structure already in place. What categories of DCD are feasible in India? If anyone here in the panel or you would quickly like to comment?
So type 1 and 2 are going to be difficult because it's an uncontrolled situation and we don't really have the kind of infrastructure to revive patients or do good quality CPR at home or in the community. So we are at this point looking at category 3, 4 primarily and maybe to some degree 5 also.
Thank you. So just to show that we thought about all this in 2014, and I wanted to project this slide. Kumud is here, Marty is there, Daraj, you are there. 10 years ago we held this meeting and we are still talking about it, but I think a lot of distance has been covered. We are almost there now with everybody there. So 2022 we have already published our first guidelines and everyone can go through in India, whoever wants to do DCD. And the good thing we did was that in our country the problem is there has to be a 6-hour interval between the first set and second set of brain death tests. A lot of people we lose during these 6 hours, and some people were doing a CPR during this time if there was a cardiac arrest. So the way out we published in 2022 was here that if the patient is unstable, we sign a do not resuscitate from the family and then we don't have to do a CPR in that situation and go ahead. So this was the way we suggested, and it's a good practical solution. Is withdrawal of life support allowed in India? Yes, we have discussed this, and for the people who want to go through, this is now available as a nice paper written by the Society of Critical Care Medicine, Primary Medical Board, Secondary Medical Board, and the process has been made much easier. We have another consensus statement on how this is to be done, DCD in three situation, 2024. So a lot of hard work has already been put. You can see there are 12 societies on the right side shown who are involved in producing all this documentation, and the pathway for DCD-4 has already been discussed. Now withdrawal of life support has started. Maharashtra was the first one to go ahead. Goa also, I am told. Karnataka. So three states have already said to start withdrawal of life support, and we are gradually trying to do more and more of this. But as we just to show you how much of the activity in India so far, we have done 68 kidney transplants DCD, 33 in Ahmedabad, 30 in Chandigarh, 4 in Nagpur and 1 in ILPS. We have done the first pancreas DCD transplant, which is very heartening. We've tried a few super rapid recovery livers which have not worked. So the obvious solution would be the Nrp. We tried the normal thermic machine perfusion in 16 patients. It became very expensive and orthodox left the country. Hypothermic, the HOPE one, is still being used once in a while. So the obvious way, as Eduardo was saying, is to go for Nrp. And our consortium that we established, we have been at it for about a year and a half now. This is our mission statement, and I think we are ready to publish our consensus. We've met about 12 times so far. So with this background, I'll hand over to Ravi, who will tell you what we have written regarding the next step of WLST and establishing Nrp.
So this is the WLST team that will basically initiate the process of withdrawal, and it will include ICU specialists, nurses, hospital administrators and brain counselors. Then there is the procurement team, which will have the cardiothoracic surgeons, the heart and transplant surgeons, sometimes even vascular surgeons, because even if we are just doing a peripheral or abdominal Nrp, we may need their help to put them on the Nrp. And then of course cardiac anesthesiologists, liver or abdominal surgeons, ECMO specialists, perfusionists who are experienced and trained in this, scrub nurses who are consistently helping us with the same cases, transplant coordinators, just to coordinate everything and the central to this whole process. We have also designed an additional consent form to go with our the process and the documentation for which is required. And we're going to make some minor changes, but this is vetted by legal teams in India who specialize in medico-legal cases in the OR. And in this case, the algorithm is similar to what has been discussed so far, which is, prepped and draped in the OR, withdrawal, followed by monitoring, and when the systolic is less than 50, then the functional warm time starts, and after pulselessness, 5 minutes of no-touch period, which is also in the same area, followed by heparinization and change of cannulation, and the Nrp is initiated, followed by observation for about an hour, and then if organs are suitable, then go ahead with procurement. Second scenario is when the withdrawal happens in the OR and there is peripheral or abdominal Nrp, which is what is more commonly practiced in Spain. This protocol for the same will be very similar to what has been described so far, except for the access, which is going to be through the abdominal iliac vessels. And we have a sort of homegrown circuit which comprises of an ECMO circuit followed with a capacitator and an oxygenator to do that. The scenario 3, again, which is more commonly done in Spain or in some other European countries, is withdrawal in the ICU and procurement in the OR. Now here it will obviously has to be peripheral Nrp through the femoral vessels. And here the protocol is going to include, in addition to after the patient is on the NRP, they will have to be shifted to the OR for the procurement, and that's going to be slightly different, and also will require the EVOPA balloon to be put and verified before NRP started. So those are the two differences between these three scenarios. But as a country, we will have to be ready for all three scenarios, because we'll have different situations in different states, potentially requiring different skill sets to be available. There is a checklist we have made for every hospital who wants to do it. Basically, you just make sure that you have the right infrastructure, right donors suitable, you have all the legal and ethical approvals, and then you can, as long as you try to complete all the check boxes, you should be okay to go ahead. And then these are becoming more and more standard as to which organs should be used, and most commonly now we have narrowed down to lactates which are stable or decreasing, and gross appearance or biopsy of the liver to decide whether or not you're going to use them, and again urine output, and in addition to a biopsy of the kidney to make those decisions for the kidney. So for heart and lung,
before we go to the heart and lung, we are going to project the animation of the abdominal NRP and thoracoabdominal NRP. For people who missed the morning session, we'll just run a little animation just to show. And then thanks to Jumana. Jumana, are you there?
Yes, sir, I'm here.
It'd be nice if you can show in a couple of minutes your fantastic animation.
So you can start with the checking. So this is the abdominal NRP. You have a cannula and the inferior vena cava running through the reservoir to the pump and back to a cannula in the femoral artery. Through the iliac we can put this, and we have to clamp the abdominal aorta above the celiac axis. That is a hemodrome to keep the temperature 37 degrees, and the cephalosplendour giving oxygen to the oxygenator at FiO2 ranging from 20 to 50, aiming for an SCVO2 of around 60 to 70, and we keep the sweet gas flow enough to maintain a pH and not cause any hypocapnia. So we usually start with 0.5 to 1 and titrate it to make the ABG PCO2. In the thoracoabdominal, the cannula is in the RA, the access cannula, and the return is in the aorta. The circulation to be started after clamping the arch vessels and opening the brachiocephalic to air. Insertion of the PA vent catheter only if lung retrieval is planned, and air vent catheter if heart retrieval is planned. The rest of the hardware is similar. These are both in OT procedures.
Thank you very much. That was really nice.
On to the next slide, please. And the donor selection also remains exactly the same, except for hearts, where currently the DCD practice, we are suggesting that donors above the age of 50, particularly in the absence of any coronary angiogram, is probably not a wise idea. And lung is very similar. The issues here are that you can do all this protection of antegrade, retrograde at the time of the retrieval, and that reintubation is absolutely necessary to avoid, as I mentioned earlier, gastric contents contaminating the airway. So lung retrieval in the setting of abdominal NRP, we've just been through that with Eduardo's really wonderful explanation and how they actually got a hybrid model because they cannulate early of doing the abdominal NRP, converting it to a differential temperature, and then converting it to general TA NRP when all organs are being taken. So the important here for lungs is that it allows you time to do the bronchoscopy. It's important if you go back to the early days of DCD, including even with the Nrp technique, if you look at the data, the number of lungs retrieved were actually quite few. And there were a lot of issues and people were wondering why this was happening. Well, hypoxia does cause acute vasoconstriction of the pulmonary vessels and cause an increase in PVR, and hence it's important to vent the pulmonary artery. The other thing is that you really need an experienced team to secure hemostasis when the heart and lung team are leaving, and the abdominal team should not be faced with continued blood loss and having to further hemodilute their NRP circuit. You can retrieve the heart even in the abdominal NRP setting from direct procurement, but as we've seen, it is exceedingly expensive to have an excited perfusion device, and it's highly unlikely we will have that setting in India, and therefore I completely agree with what we've been saying so far, that the thoracoabdominal NRP technique is ideally suited to allow in situ assessment, validation, and then do a standard static cold storage, which has now been shown, validated both in Spain and with some of the centers in the United States. And again, here in the TRP setting, I'd just like to concentrate for the sake of time and open up on discussion with the fact that you do need the perfusionist to be on the ball. It is exceedingly easy. If you don't have, I say this in the Indian context because often these things are taken for granted elsewhere, that we do need to be observant about the amount of flow we're utilizing, what is the level of the fluid in the reservoir, and the thinking and acting time they actually have at various levels of flow and reservoir volume. So to have a level sensor is very, very important. I'll leave it there because I think I'd like to open up discussions more widely, particularly given we've got the benefit of such eminent international speakers here today. Thank you.
Thank you, Prabhu. Let's stop sharing the screen and after this closing remark, and give us the way forward to India. So, who wants to start? You have a flight to catch. So Ravi is going to be the opening batsman here.
Yeah, so I think we've come a long way in the last 10 years since we started, and especially in the last 2 years since we have, 2-3 years since we have published some of this. And the way it has to be done in India is very different from how it is done in the West because of resource constraints, and at this point everybody's comfort level has to be more before we start doing it, and withdrawal is not so commonly practiced, so that has to become a norm. So things like that, but we are there, it will happen very soon.
Thank you. And Ashish, I can see you there in the audience. Ashish is from PGI Chandigarh and has the maximum experience of DCD kidneys. He's done the only DCD pancreas in India. So, comments from you, Ashish.
As was mentioned by one of the speakers, that we're trying to do all the three things together, right? So my take would be to, right now I think we probably need to focus on ICUs in areas where there are teaching hospitals, so that this message of withdrawal of life support starts to go in the community. And once that happens, I think then when DCD is a natural byproduct of that.
Yes. Dr. Bharti, would you like to say something before I get our Director Gordo on board?
No, only just congratulate for the progress in the last 10 years, that you did, and now the technique to do, as you see from our colleague from Minneapolis, for the number of organs utilized by the results. But again, the key point, as also my friend from the States mentioned, intensive is the point. And the withdrawal treatment with sedation is the point. And then you never will be upset because all the potentials will go on. Then the techniques, whatever you use, will be excellent, no? And just something that legally, and here is Anil Kumar, I recommend you introduce in the future the possibility to put empathy before the procedure, and second, to do the prayer cannulation before build-out. That is changed completely. You have the body in the normothermic machine perfusion. The body is perfused. You can calculate lactates. That changed completely our. And remember to you, only my region, 62% of the cases today are DCD. If ICU people was not aware, these cases will not exist. And Nyambe said important issue. The sedation and anesthesia at the care of the end of life is not only for donation. It's any patient who is fertile to care. It's a good for the people to die with comfort.
Yes.
Anything we need. Next year we have a workshop in Spain, as only as you attend many years ago. The time now is in Barcelona and A Coruña because animal are there. And I recommend if some of you want to join, will be happy for me. And particularly I will invite Ugo Dital, my friend, to join to see the model.
Thank you so much, Marty. Brian, any last comments?
Just to have to reinforce what you were saying and what Dr. Ashish also mentioned, that the only way to move forward is to involve the ICU. I understand that's the only way to make this thing possible and sustainable.
Thank you, Brian. Darius?
So just still to reiterate the earlier point that there is an issue with trust in India about accepting brain death. So DCD donation provides a unique opportunity to bypass that trust issue that still exists. But you do need to take on board, it has to be ICU driven. And again, I said this before at meetings, really start with a few pilot centers where the environment and the ecosystem is completely geared to this. Because there will be lots of enemies out there pointing fingers. We all know that has been a big challenge. We're a small group of people. And the people who got views against this are far, far larger and far, far more influential.
Thank you, Darren. Chris, any last comments from you?
No, I wish you luck. I think it's a fabulous initiative. I wish you every luck in taking forward.
Thank you so much. Now, some of the issues that Darius just raised, we're hoping as a clinical consortium that we might be able to mitigate that with the, we've had Dr. Kumar here throughout these meetings, and from his position as Director of NATO, I think will help us to actually translate this into a comprehensive clinical program, and we'd love to hear from him in the last few words of how we might go about doing that.
Yeah, thank you very much. Actually, what we realized that world has progressed in the terms of DCD donations, and now almost all the countries which are doing well in organ donation and transplantation, they are doing a substantial number, and we are lagging behind. We are realizing that. So we need to move forward. And we need donors. So so definitely this initiative, which is like some of us and particularly we are very grateful to Dr. Anish and the MOST family and the clinical group of hospitals for so long he has been pushing for this DCD donation, and many of us, Dr. Shroff, Dr. Mathur, and all of you international experts, so they are all contributing. So it's really time that we should be moving in this direction also, and some of the donations have happened. Some of the centers have already done successfully, but the way it has to happen, the more in a controlled situation after the withdrawal of life support. And we have to also look at what all anti-mortem interventions can be allowed in India, which can be acceptable to the entire scientific community. That also has to be laid down. So definitely national level guidelines are required to move forward in this direction. Once the directions or the guidelines are in place for everyone to follow, I don't see any any hurdle then in implementing this, and we have to move with the way the world is moving. So we cannot be like that.
Thank you so much. And finally, I'd just like to come back to get some comments from our very senior clinical experts here in India. I mean, Dr. Mathur, who today only I discovered was doing in his lab animal liver perfusion back in the mid-80s. So congratulations.
What Dr. Kumar said, I will take it from here. It is doable in our country, we have to catch up. See, when brain death law was in this country, and I have got cutting witness to all those things. So, we have moved, and DVD is recognized, people are recognizing, and donations are happening. And across the country, it's not that initially it started south, west, now it is spread over. So, same thing will happen with the disease. It's a question of starting. The first step is to be taken properly, as you said, that because all these things which we have done for last 5-6 years to draw the protocol. Once those protocols are in place, and as Dr. Kumar said, that the guideline, national guidelines are issued, the people will be more comfortable in doing it. Their mindset that is the law against us, is it difficult, all those can be sorted out. And to begin with, to simplify the things, I think we should start with the type 4, type 4 DCD, where the people acceptance will be there. And then, as the WLST becomes a norm in the ICU, in the hospitals, we take it to the organization. That's what we say.
Thank you so much. Sunil, any comments?
I think I agree with all of you. I think it's going to take time for the intensive care people to be brought in. But we have to move forward. And when we started this consortium also of discussion, what at least I realized at that time was that we have to start doing master criteria for donations immediately in our country, and that's not very challenging. And there was a lot of resistance to that as well. In fact, even today there is resistance. Last year, 2024, we did about 1,250 DVD donations. Believe me, there would be another 300-400 where consent was given, but donations didn't happen. And that would have been easily DCD donations. And that's where I think the first hurdle is that if there are some guidelines available, that if you have a brain repair, you're not able to do the second, apnea test, go for DCD. If that clear guidelines come to everybody, I think our DCD numbers will increase. Straight away we will start doing a considerable number of DCD, at least for kidney and liver, definitely. Withdrawal of care is going to happen, that's going to take time. Are we going to wait that long? I don't think so. This program belongs to intensive care, no doubt about it. But unfortunately, not many intensivists are on board with this program. Because we don't have uniform declaration of death in this country, there's still ambiguity about death itself. So, and most of our program is in the private hospitals. 80% of transplants are done in private hospitals, so there's a distrust as well. 20% are in government hospitals. Unfortunately, most of the disease donor potential is in the government hospital. Most of the recipients are in private hospitals. So there's an equity disbalance. And that's why I think practically to move forward, concentrate initially on this 4, criteria 4, slowly graduate versus 3. 3 should be taken up by 5 centers as already discussed. And I think that's the way forward.
Thank you, Sunil. And finally, Philip, any pearls of wisdom before you head back to the US?
So, right from the beginning, I've been sensitive to 2 things in India. And it's have that, we want to avoid that, we want to build up our counseling services. But the second thing is, will these organs work or not? Any program will founder if the organs don't work. Now, what I've found is that with DBD, it is pretty darn difficult in the ICU to manage a patient who's brain dead. When I started the program in Kerala in 2013, my first imperative was to get 2-on-1 nursing on the dead patient in the ICU. Whereas the living patients had 1-on-1 nursing. So it's so difficult and labor intensive for an intensive care setup to manage a DBD efficiently so that all the organs work well. That problem is not there with DCD. So we are actually dealing with a situation which is likely to succeed because it is easier to do for the intensivist. So that is one point. The second point I would say is that we are now able to tell the recipient hospitals, this liver is going to work, which we can never do with DBD. After the time you open the patient on DBD, the liver is steatotic and you are wondering, nothing like that. You can guarantee this will work. And that is going to be the strength of this program in India. So with that I would say, great job Abhish, and all of you who regularly sat and put the consortium notes and the publication. I have to admit that a lot of things I learned from that, and a lot of things are difficult to understand. I just landed in a place where it was easy to do. So that ease of doing helped me, and I would like to translate that kind of spirit. कि इतना मुश्किल नहीं है, we can do it. We got excellent surgeons, we got excellent intensivists, and if we decrease the pressure and load on the intensive care, I think they will come up with more.
Thank you, Philip. As we saw today, we had the infrastructure to implement from the people who have joined online. Yes, you are saying.
First of all, congratulations to all of you. You have done a death certification and the transplant, the donation process. So that is one thing on which we have to work. So there is a, as Dr. Darius said, there is a lot of distrust or a lot of who will point fingers at you. But the thing is, first of all, we need to start certificating that cardiac death or brain death, and then as a corollary, then slowly, then we need to take it towards organ donation. That is one thing on which everyone has to work.
They all started together. So today, when we did the fourth BCD around 21 days back, now the setup is a bit more mature, except the things. So what we have done is uncontrolled, and we do want to move to the controlled DCDs. So it's definitely very, I feel that we all should accept and we should move forward. Thank you.
Thank you, Chris, for hanging in there. Thank you very much for your presentation. We loved it. Eduardo, we can't see you, but enjoyed your presentation. And thank you to everyone in the room for sparing your time. Let's take this forward. I can see the energy happening all around, so we'll see you all more often. Thank you very much. Bye-bye.
Thank you, Amish, for getting us together.
Most welcome, sir.
Thank you very much.
Bye-bye.
Bye.
Thank you.
Letting us together and holding us together.
Yes.
Working on the detailed brainstem health guidelines. So that is already constituted, and we want to select people from that group itself, and we would like to also on board, and then move forward to PCD also. Because this group is from the society. We have Indian Society of Critical Care Medicine, we have Indian Society of Anesthesiologists, and Surgical Society.
The 8 societies actually we got on the consensus. All the websites.
Those papers can be put on the .2 website. The consensus documents. People can read at least.
Those papers are part of the nation. They have their own committee. Which all the societies are.
But any of the society members are
they are not there. They are not there. So BSD group actually doesn't have you or him or
then we come on board and then talk to them. What are their apprehensions? What are their expectations? And it should be even very lively discussion we had.
Okay, yeah.
Look here, sir. Sir, look here, please.
This meeting happened because Philip said great spirit and it works. Thank you. It was really wonderful of you to say yes.
Senior
Yes. Come on, center, please.
Sir.
Sir, this side.
Thank you. Thank you for coming. This is a very nice mission. Thank you, sir. Next one is absolutely. One phone call and he is here. Absolutely amazing. So we have some enthusiastic people who reached out and said, can we come? I said, no, this is what we need, you know. These are the people who really matter.
We need more candidates to get the same thing would happen.
Say no to anybody. Hi, not to.
So I am involving more in the technical, I just wanted to
Since he's from Nrp, I'm going to give it. आइए ना सर अरे हम बात कैसे करें हाँ
Look here, sir.
Yes.
Thank you.